affect the prognosis, affect the future of a human being, especially when we're talking CKD, COPD, and chronic heart failure. Without any doubt, this topic is one of the most important ones. Moreover, I would say that there are a lot of undercurrents, and we'll be discussing these issues. Well, without much ado, I would like to give the floor to the first presenter, to Professor Mikhail Batushin, who is a nephrologist. He will be talking on the issue of physical training and CKD. Professor Batushin, the floor is yours. Dear Alexander, dear colleagues, the thing is that the problem of physical training in CKD looks new, although the problem is very old. I remember the time when 25 years ago, I encountered patients with renal insufficiency, and doctors were very cautious, telling them how they should go to the dialysis center, how they should not be involved in physical exercises, do not do any sports. So that was a new cast. So to say, such patients should not move a lot. They should be at rest. And it was supposed that they will make it to retirement. But renal pathology is basically the same as the lung pathology, pulmonary pathology. And the thing is, in all such cases, when these organs are injured, one way or another, physical rehabilitation plays a very important role in terms of improving the quality of life and extending the life expectancy. There are a lot of studies devoted to the assessment of physical activity, tolerance to physical exercise in patients with CKD. In general, you can see this tolerance is lowered by 1/3, in some cases by half, depending on the study. This is not new. Why does this happen? First of all, this is due to the fact that such people have clinical manifestations which are obstacles on the way to leading a healthy lifestyle, such as swelling, edema, insomnia due to nocturia, high blood pressure, diabetes mellitus. Suffice it to say that some of them have had myocardial infarction, brain stroke, and of course, this leads to minimal physical activity, to problems with movement coordination. I should say that anyway, there is some kind of internal predisposition regarding physical activity. Many patients say, well, Mikhail Mikhailovich, do not tell me about this. I have the kidney pathology, and that means I have physical exercises contraindicated. Well, we hear such things virtually every day. I should say that patients with CKD have the damage of muscle tissue, have the protein and energy insufficiency developed, as well as sarcopenia. I'm not going to talk about the reasons for that in this presentation, but there are lots of reasons for that. First of all, uremic intoxication, the ability to have an impact on mTOR and muscle anabolism through the zone of proliferation, and the alimentary independent process of development of sarcopenia starts. Also functional limitations, or sometimes it is called PCMD. So these are clinical limitations of movement. And finally, dismobility or disability. This can lead to frailty. Everyone understands what frailty is. We don't even have a proper Russian term here. And by the way, this is an important risk factor of patients with renal pathology and the progression of renal dysfunction when patients are put on a dialysis machine. While uremic sarcopenia and protein energy insufficiency are interrelated with the pathological process per se, such as cytokine surge, inflammation, vascular and renal remodeling, issues related to cathexia and other pathologies such as depression. A patient who has compulsive disorders is usually not compliant in terms of physical rehabilitation. There might be endocrine disorders such as anemia. It can be anorexia. And as you know, when you do not have proper diet, it's difficult to maintain a proper physical activity, to mention but a few. I should say that the renal function is closely linked to the physical activity. Just look here, there are different age groups, but nevertheless, the lower curve, the middle curve, and the upper curve just show the peculiarities of the physical activity. The lower the renal function is, as you can see it, SLCR less than 60, the lower the physical activity is. With age, this is worsening. As for overall survival in terms of the frequency rate of hospitalizations is worse in those patients who are low on physical activity. This is the 60-month study EXCITE that shows that the less the patient is mobile, the less the patient is involved in physical activity, the more often he gets sick and the more often he gets hospitalized. A 6-walk test, weak hand grip, all these factors are closely linked to patients with chronic kidney disease and with the outcomes of this disease, with mortality. This 3-year study, there were 50 deaths, 13% of patients died. Mostly those patients died whose physical activity parameters were low. Finally, physical exercises, when we're talking about patients on dialysis, and of course, doctors say, we should not just tell them about the need of physical activity, but if they become at least physically active to some time, this increases tolerance to physical exercise. This improves the quality of life because their quality of life is very low. Patients on dialysis are the most difficult group of patients in terms of socialization. Here is the other study similar to Framingham. It's NAINS, conducted in the US, conducted for several decades. 2011, 2014, they took a sampling of patients, they monitored them, and last year they published an interesting study that showed that patients with low physical activity had the progression of dementia, and it is associated with the progression of chronic kidney disease. At the same time, patients with high physical activity do not have this correlation with CKD. So patients, thanks to the physical activity, breaks this link between renal dysfunction and dementia, or the intellectual capacity. That's very important. The entire range of exercises for patients with CKD can be divided into 4 parts: aerobic exercises, walking, strolling, dancing, also resistance exercises, bandage wearing, weight lifting, push-ups, sit-ups, and also balance maintenance, walking a straight line, yoga, and so on and so forth. So here you can see some pictures. These are patients who at this moment, as you can see in this picture, are on hemodialysis. And you can see here, there is a bicycle exercise. And of course, you can say this is perversion. Let this patient have a procedure and then he can come home and can just 15 or 20 minutes rotate the pedals on the bicycle. Why should he do it during the dialysis procedure? Studies have shown that if you do it during the dialysis procedure, the muscle cells reach in phosphate, and thus phosphates are in the cells, and in order to get them out of the cells, it's important to activate this cell functionally. So muscle cells during the dialysis become active, phosphates get out, and they can be removed through the dialysis membrane. Why should we do it? Hyperphosphatemia is an independent risk factor of death for patients on dialysis, like LDP cholesterol is dangerous for people of high risk, so phosphates also can cause damage to the cell, especially lead to death for patients on dialysis. Exercises allow us to purify blood during the dialysis procedure from creatinine, from urea. Of course, these are indicator molecules, but there are middle mass molecules who have toxic properties. Phosphates are removed much better if you do physical exercises during the dialysis, and the removal of phosphate is just excellent. There are other ways of fighting hyperphosphatemia, but physical exercises between dialysis and when the patient is on dialysis will adapt the patient to dialysis procedures. The procedure of dialysis is much better in this case. Tolerance is increased, the quality of life is increased, and we can prolong the life of such patients. You can see aerobics, riding a bicycle, swimming, well, flexibility exercises, and the frequency of such exercises for people with renal pathology, aerobics once or twice a week, then 3 or 5 weeks, 3 times a week, and then you can continue such procedures. As for resistance exercises, once a week for the first 1 or 2 weeks, and then you can see other parameters describing the intensity and the duration of such exercises. Please pay attention to the fact, as for aerobics, for example, or resistance exercises or flexibility exercises, usually they last no longer than 15 to 20 minutes. We do not have bodybuilders. We do not have high performance athletes. What is important for us is to return a person with renal pathology back to life. And for that, we use physical rehabilitation. We do it incrementally, carefully, but rhythmically. As for the basic activity of patients, such patients with CKD can have a different type of activity. This can be patients who can only sit with minimal physical activity, or there may be patients with a sporadic physical activity who are quite physically adapted to a specific exercise. So in all 3 categories, the frequency rate of physical exercises is 3 to 5 days per week, but the intensity can vary from light to moderate and even to heavy intensity. The duration can be longer, from 20 to 30 minutes for patients who have a sedentary lifestyle, and up to 90 minutes if you look at 3 stages, aerobics, well, and other 2 stages. As for walking, right now patients have cell phones, different devices that can register the number of steps, speedometers, etc. At the first stage, 3,000 to 3,500 steps and up to 7,000 steps per day. Well, you encounter patients with such pathologies, and I hope that this presentation will change your mind. So you will just recommend not specific drugs or psychological and social rehabilitation of our patients, but also you will be dealing with their physical rehabilitation as well. Thank you very much. Thank you very much, Professor Batushin. That's very important when we're talking about physical rehabilitation or physical training in patients with CKD. You mentioned the lipid profile, and I would like to touch upon one very important thing. Right now, we know that physical exercises are useful to CKD patients, but we must also realize to what extent they can be useful. Some say, no, physical training doesn't have an important impact on prognosis, but on LDL, here the situation is different. So let's shed light on this question. Can physical exercises reduce LDL? And I should say that my presentation is very controversial because we will have a different look at the situation regarding physical exercises of patients with dyslipidemia. So right now, whether physical exercises are useless or useful, well, there are two aspects to this question. So please be very attentive when we're talking about physical exercises. We should not say that it's just useful and that's it. Well, so what is the probability of dyslipidemia? What is the probability that your patient will need physical exercises to control the lipid level if we look at this situation from the point of view of statistics? And this slide is very interesting. I showed it during my previous presentation. It is important to understand that the levels of lipids, well, has nothing to do when we're talking about the lipid level of mammals as compared to the modern man. So the level of lipids in modern men is higher as compared to animals or mammals. The left column are animals, then neonates. The third bar, hunter-gatherers, and number 4, modern man. So you can see that primitive man had normal lipid levels, but in modern society, the levels of lipids are very high. It's due to hypodynamics, poor diet, smoking. It's a combination of different factors. Can physical exercise maintain the same levels of lipids as if we were holding the healthy lifestyle? Here are Russian data at the age up to 35. These are young people. LDL levels are lower than normal level in basically 46% of men. So more than 50 have the elevated levels. Here you can see the recent guidelines of 2023. These are clinical recommendations of the Ministry of Health. Is even sadder. We can see significant LDL levels. That's our reality. And we're talking not just about low density lipoproteins, but also about atherogenic dyslipidemia, where we can see triglycerides are elevated, LDL are elevated due to the use of alcohol, poor diet, lack of physical exercise. And before I move on to physical exercise, I should say that there is an opinion that maybe it's not a dangerous type of lipid elevation. No, there is the 5th type of dyslipidemia, when we have high triglycerides and normal LDL. So no, this doesn't work. And the last item is that patient may not be genetically predisposed to atherosclerosis. This is a very small category of patients. Well, 1 out of 200 people who have PCSK9 protein mutation. And this mutation occurs in a small number of cases. They won't have atherosclerosis, but 99% of modern people living in cities, living in rural areas, nevertheless, will have the high level of lipids and dyslipidemia, and they will have the heavy atherosclerosis. But another problem is plug instability. We can have obliterating atherosclerosis, but unstable plug may cause cardiovascular diseases and even death. Sometimes people say maybe we do not need statins. Well, we can talk the patient into living a healthy lifestyle? Well, 4% of people live a healthy lifestyle after doctor's recommendations. 96 do not do it. But even if we're talking about a healthy lifestyle, all authors refer to the same studies where the average level of LDP reduction was 14%, both when we have normal diet and physical exercise. So it looks like a healthy lifestyle doesn't have a significant impact on dyslipidemia. But this is not exactly so, and here we have very interesting aspects. We must figure out what particular physical exercises can have an impact on the level of LDL, and to discard the idea that this is impossible to lower. Fatty acids participate in the energy formation until they achieve 65% of the peak oxygen consumption. I should say that, well, VO2 max is at the level of 46% in a 25-year healthy man who does sports, but 65%, well, is the level of an elite athlete. In women, this indicator is lower, and this is very interesting. Only elite athletes can have a normal level of LDL, so a normal person cannot have it, and up to 6% of patients have the mechanisms destroying fatty acids, plus other mechanisms such as activation of NGPTL4 participating in the regulation of lipid exchange. So we have intensive exercises and super intensive exercises when we have another mechanism involved. So up to 65% of peak VO2 have the ability to destroy lipids directly. And after 65, there is another mechanism involved in the regulation of lipid exchange. The first idea is, can we lower lipids by super intensive physical exercises? Well, what's the problem here when we're telling patients about high risks and there is a young patient? The patient goes to the gym and starts weighting lifts, super intensive physical exercises. In order to answer this question, I give you the results of this study. 10 elite athletes ran a super marathon, 100 kilometers without stopping, with the height up to 4,500 meters for 17 hours. It's hard to imagine any of our patients who can do something like that. Nevertheless, the results are very interesting. We had the activation of AGLBD4. We see this activation, and on the basis of ANGPTL4, there is a drop of triglycerides. They dropped twofold, but when we're talking about LDL, there is a reduction, but it is not quite significant. So even such super intensive exercises cannot significantly reduce the level of LDL, but can reduce twofold the level of triglycerides. That's very interesting. Maybe 100 kilometers is not enough. Here is another study, the ultra marathon, 133 to 170 kilometers. It's not just a 42-kilometer marathon, but up to 170 kilometers, that's like 3 times as much. 16 elite athletes, the drop of triglycerides by the end of the race up to 0.2 per liter. But as for low or high density lipoproteins, they haven't significantly changed. So you can see that super intensive exercises do not yield us such results as the drop of LDL. What about less intensive exercises? Well, I should say that you cannot just run an ultra marathon without any preliminary training, but we can exercise every day. What do we know about such exercises? There was a meta-analysis. There was a drop in LDL by 14%. Well, you can see aerobics, light aerobics, and non-aerobics. As you can see it here, such as gymnastics or weighting specific lifts, 50 women of near menopausal age, around 50, and they were exercising for 12 weeks on a regular basis. They were randomized in the group of aerobics, walking or jogging, or non-aerobics, burden, cyclic exercises with some weight lifting, and VO2 max improved from 27 to 31. In general, that's a good result, but there were no significant changes in the lipid profile. And of course, there was the drop in general cholesterol, but not significant. Here is another study, a combination of calorie intake depending on exercises and the risk of cardiovascular diseases. The level of lipids was assessed. Well, you can see the first column, exercise, CR, that's calorie restriction. And in both groups, there was the comparative drop of LDL by 0.4, which corresponds to 20% from the initial basis. So that's not a phenomenal result. Moreover, the diet gives the same result as physical exercise. So it looks like traditional exercises can have an impact on LDL, but not quite a significant one. Let's look at the large meta-analysis. The minimal threshold of physical exercise can have an impact on lipid serum, despite the fact that these changes are minimal. The main positive change is the change in LDL cholesterol, which can fluctuate within 10 to 15% in some patients. And well, usually it's a man, 37 years old. He came to see me. He listened to the presentation. He knew that his cholesterol is very high and LDL is about 4. He came to me. He had obesity. He smoked. He drank alcohol. I don't remember all of his indicators, but he said that he was ready to change his lifestyle, and he did it. This is the only example I know. This patient, he stopped smoking, stopped drinking alcohol. He did sports twice a week, so his BMI was 23. Well, he gained a lot of muscle weight. He was tolerant to physical exercises, and you can see that there was a drop of LDL, again at the level of 3.5, 3.7. There was a drop by 0.5. So it looks like it doesn't make sense to do sports or to do physical exercises to lower LDL. So this is the main intrigue of this presentation. Let's look not at those people who did some ultra physical exercises and look at those people who do sports regularly, 3 or 5 times a week. And also, let's look at those who are in between, who do regular exercises intensively and observe the diet. These are people closer to the category of professional athletes. This study included not just professional athletes, but also people who do physical exercises on a regular basis. Who were those people? Like people 22, 34 years old, and these were people with BMI 22 at the beginning of the study, the ideal BMI with the small percentage of fatty tissue, 9.6, 7.8. So these 3 groups are athletes, but some had low carb diet, such as keto diet, lots of fat, lots of protein. These are people who ran ultramarathons. They needed to accumulate energy. The second group are high carbohydrate diet. And here we are talking about fruit, vegetables, well, porridge, etc. So you can see BMI is different. Body mass is 66, well, SD 6.8. So you can see, well, the average athlete is 45. Here it's 64. Well, VO2 max is 64. So you can see this indicator is much better. Their cholesterol level was different by a factor of 4, 291 in high carbohydrate diet group and 844 milligrams in the low carbohydrate diet. Well, and you can see, if we compare the lipid profile, we can see that there are some wonderful changes. Well, you can see the results here, and their level of LDL in the first group, 2.25, the ideal result for this age, but in low carbohydrate diet, 4.1. But the main indicators are also different. Well, you can see triglycerides in the second group are lower because they burn them less, but you can see that as for lipids, they are significantly of higher values. So let's make a comparison in diagrams. Just look at the left graph, triglycerides in the group of high intensive exercise, black dots, high carb diet, white dots, low carb diet. The right corner, total cholesterol, you can see high carb diet had the lower result in terms of total cholesterol. Let's go down and let's look at LDL-C. Here are the major differences between the two groups. The group which had regular exercises every day, basically, and was on high carb diet, lots of fruit and vegetables, had lower LDL-C indicators, despite the fact that those who are on low carb diet had a bit higher values of HDL-C. Those who do a lot of sports, use a lot of fruit and vegetables, will have these indicators. So in response to the question, can physical exercise reduce LDL? The answer is yes, if this becomes your integral part of life. That means daily, highly intensive exercises, including weightlifting, including tolerance exercises, running a distance of 10 kilometers and longer. At the same time, high hydrocarbon diet, like this patient who began to lead a healthy lifestyle, and you should use a lot of fruit, vegetables of different types. In this situation, this is a unique case when we can reduce LDL due to the change in your lifestyle. LDL can be reduced not by 10-20%, but by 40%. How many patients can lead this kind of lifestyle? That's a different question. But the fact is the fact. If we can motivate a young person to change his lifestyle, the result will be mind-boggling. Thank you very much for your attention. And just a minute, let's move on to the preview of the next presenter. Dear colleagues, if you have any questions, If you have any comments, so regardless the type of physical exercises or anything like that, send your questions to the chat. We'll have time for discussion. We'll be able to answer all your questions. While waiting for your questions, I'm sure there will be some. Let's move on, and it is a great pleasure for me to give the floor to the expert in the field of pulmonology, Marina Boldina. Her presentation is called How Important is Breathing Training for COPD and Bronchial Asthma? Thank you very much. Well, good afternoon, distinguished colleagues. I'd like to thank the Eurasian Association of Therapists to make this presentation. It's always a pleasure to participate in such symposium. My question is to answer this question: how important is breathing training for people with COPD and bronchial asthma? First and foremost, I will start with chronic obstructive pulmonary disease. COPD is a very important disease, socially important. Unfortunately, right now, it is not properly diagnosed. We have problems with diagnosis of COPD. COPD ranks third globally among the major death causes. That's the disease which leads to disability, and due to the course of this disease, it restricts patients' physical activity. What is happening in case of COPD? Obstruction of airways, hyperinflation, especially the static one, when the lung volume increases at rest, dynamic hyperinflation, when this lung volume increases with physical exercises, and the increased demand in inflation. This leads to shortness of breath, which limits patients in terms of physical exercise. And there is a vicious circle, and hypodynamics, the muscle dysfunction develops, and thus you can see the disease begins to progress. In speaking of physical activity of patients with COPD, this study shows that even if it's COPD which is mild in nature, and you can see it's a mild and intermediate stage, but the physical activity is reduced significantly in patients with COPD. And this reduction in physical activity leads to the situation when the quality of life becomes lower. Also, there is the increase of the obstruction of airways. There is an increased probability of hospitalization, and there might be severe exacerbations, which may be a life-threatening condition. And that's the situation when the patient may not come back to square one as far as the lung function is concerned. Well, any exacerbation may lead to the progression of disease, and as a result, to an increase in the mortality rate. So that is why this has been proven by different studies. Here you can see the graphs. The reduction of physical activity is an independent factor for an unfavorable prognosis, and COPD is one of such reasons. We can see active patients, well, patients with the reduced activity, that's the light blue line, and non-active patients, that's the gray line at the bottom. Their life expectancy is significantly lower as compared to those people who lead an active lifestyle, do breathing gymnastics, and perform physical exercises. If we look at the criteria or predictors of death for patients with COPD, we can see that the level of physical activity ranks first. So that's the most important predictor of death in patients with COPD. Daily walking, FEV1, well, excessive body mass, 6-minute walk test, BMI, well, Boulder scale, well, MMRC. Well, you can say these things are important, but the level of physical activity ranks first. That means that patients with COPD who lead a more active lifestyle will prolong their life. In speaking of the increase of the level of physical activity, in general, that's the key to reducing pulmonary exacerbations during COPD. Of course, approaches to increase physical activity can be different. Medical, well, medical drugs can be one of them to reduce hyperinflation, and of course, especially for people with shortness of breathness. So drug therapy can improve the tolerability of physical exercises. And of course, it is important to take into account pharmacological exercises, pulmonary rehabilitation, which gives its results. Well, the usefulness of physical activity is quite significant. Well, you can see that FEV1 is improved. People can reduce shortness of breath. Well, in this case, the quality of life increases, the quality of life improves, well, a reduction in hospitalizations, and a result of it, all-cause mortality is reduced in such people, because often people die from cardiovascular diseases. Patients with COPD usually have cardiovascular diseases twice as much as compared to people without COPD. Reduction in all-cause mortality in patients with COPD is very important, and usually this happens in physically active patients. Well, you can see the systemic inflammation in people with COPD and the impact on it of physical activity, C-reactive protein, and interleukin-6 levels. So the major physical burden that, well, we have a poorly developed pulmonary rehabilitation in our country, and unfortunately, at least, we urge patients to have 10,000 steps per day, to walk more if possible. And you can see the number of steps per day. We looked at the reduction of these indicators. So the results are self-explanatory. C-reactive protein and interleukin-6, well, dropped if the patient was more physically active. So the more steps a patient with COPD did per day, the lower were C-reactive protein and interleukin-6 levels. So this gives us ground to make a conclusion that non-systemic inflammation is reduced, and as well as the systemic inflammatory, and we know that there might be systemic inflammation leading to depression and osteoporosis, especially in patients with COPD. So here we can get very good results. What else can we take out of the study? Regular physical exercises have an impact on progression of disease. And here you can see the long-term study when we assessed physical activity for several years in patients with COPD. Well, as you can see it here, and you can see about 2,300 patients, time to first hospitalization for COPD was longer if patients had high or moderate physical exercises. Patients with low level of physical activity had a higher frequency rate of hospitalizations for COPD exacerbation. And also time to death was different between patients with high physical activity. Their life expectancy was longer as compared to those who did not do any exercises. Even the low level of physical activity, like walking or bicycling for less than 2 hours per week, that's not much, but it was associated with the reduction of the hospitalization rate with COPD by 23%, basically by 1/4. So maybe it's not much, but nevertheless, we can see there is a reduction, and you can see that hospitalization means a severe exacerbation that causes the progression of disease. What else should we pay attention to in patients with COPD and physical activity? Here you can see the data for COPD patients. Well, and you can see the test with shuttle walk when the patient walks 10 meters and the patient increases speed, and the patient walks until he can maintain the necessary speed. If the patient becomes fatigued, the study stops, and we can see how long the patient walked, what was the difference with the particular speed, and you can see patients who were on monotherapy or double bronchodilators, and there was a group on double bronchodilators and physically trained. So the group on pulmonary rehabilitation, the best results for tolerance of physical exercise was shown in the group on double bronchodilators and physical rehabilitation. So even the patient who is being on bronchodilators, the results are still worse as compared to those who had bronchodilators and are involved in physical exercises, such as breathing, gymnastics. So as for physical activity, I should say that it leads to the improvement of the peripheral muscles. It leads to a better metabolism of muscle tissues. And I should say that breathing gymnastics, well, aerobics, walking, and patients with COPD, well, can also train respiratory muscles using special breathing devices. Well, you can see one of them is here. Well, the expiration power can be set, and then we can set the bar higher so the patient trains breathing muscles, and of course this reduces hyperinflation, so the patient have a better bronchus extension and also reduce hyperinflation.
As a result of that, we can see the improvement of the quality of life of the patients, and also we can improve the relatively systemic effects of COPD. So that's another slide where I put together the data from several studies, and today we have very clear understanding that even minimal increase of the physical activity could be extremely useful in COPD. Increase of the physical activity by 30–40% reduces the risks of hospitalizations due to the COPD and the reduction because of respiratory reasons in general, and the risk of hospitalization could be reduced by 20% for any additional thousands of additional steps per day. So extra 20,000 steps. And then it is really very useful because we can reduce the risk of hospitalization by 20%. So this is a chart that puts together the data on the efficacy of the pulmonary rehabilitation, and this is extremely important. So this is level of evidence. This is improvement of the quality of life, improvement of the physical tolerance, improvement of the muscle power, grip, muscle mass of the low upper extremities, and level of evidence is always A, so it's extremely high. And level of evidence B, this is a reduced hospitalization rate and duration of hospitalization, reduction of anxiety, depression symptoms as one of the most important and systemic manifestations of COPD. And to me, this is extremely relevant. Now, speaking about patients with BA and the levels of the physical activity of these patients, So we studied to what extent patients with BA and in general, how physically active they are. And this is one of the Spanish study. A bit more than 1,000 Spanish were followed up, very different age. They were younger and more elderly patients, mature age patients. So it appeared to be that maybe not everything is so bad in asthma patients. So that's moderate level of physical activity. And the share of such patients was a little bit less than 50%. But nevertheless, 1/3 of them, 1/3 of asthma patients showed a very low level of physical activity. So what does it lead to? How it can influence this lower level. So that's one of the studies. And to my understanding, that's interesting study, although it was done pretty long ago and published. So 20-year follow-up patients with bronchial asthma, a bit more than 1,700, they were split into groups. Those who had continuous physical activity. So it was either continuous high or they increased up to high, then moderate activity in the group, and either continuous or increased up to the high one. The third group reduced to the lower one, and then lower one. And then we looked how asthma is progressing. Asthma is those who had low physical activity, they lose much faster pulmonary function. Well, definitely it's related not only with the disease itself, but also with the aging of the lungs, because you know that with age, and actually normally people lose lung volumes and muscle mass. So that's all together. So disease plus the aging itself. So these are dual action. And those patients who had low physical activity, they had definitely shorter life expectancy. That's the lowest dark curve here, the lowest physical activity. And these are results which are very similar, very similar. So if you look at how aerobic physical exercise reduces the prevalence of asthma symptoms, so this is one of meta-analysis, 11 studies where the investigators analyzed 5 studies with children and 6 studies with adults, and the prevalence of the symptoms was varied from 0 to 63 among pediatric population and up to 73% among adult population. So they were different and meta-analysis, different studies, but mainly they were aerobic loads and physical exercise, aerobic exercise and physical exercise, and meta-analysis showed that in adults and in children, aerobic physical exercise reduced the prevalence of nocturnal symptoms. I want to remind you the topic of asthma treatment, the tasks when we speak about the patients with asthma, how do we manage them and what are our objectives of the treatment. So to reach the control, that's first and foremost, first of all, current control that we are assessing by symptoms, by activity, by the need in the short-acting broncholytics that are needed to resolve the attack. And also what is important here is to reduce risks in the future, risks of exacerbation, risks of the progression of the pulmonary function, reduce risks of worsening in the course of the disease. And this is summing up slide about the physical activity of the patients with BA. And here everything is reflected. This is meta-analysis, which is published back in 2022 in the European Respiratory Journal, where we analyzed a lot of studies and looked at the influence of physical activities to the cause of bronchial asthma. So in this meta-analysis, we mainly see all the criteria that we use to assess the cause of asthma. So physical activity improve quality of life of patients with BA. Also, we see that we improved control according to the questionnaires. We see that we improve the number of days without asthma symptoms, plus improve tolerance of physical exercise and such figures like anxiety, depression. So everything is effectively reduced. Anxiety and depression are reduced in patients who have physical exercise and good physical activity and are dealing with respiratory gymnastics. So summing up my presentation, summing up my speech today, I want to finish it with this slide. What every doctor could do for COPD patients, for BA patients, to persuade to physical activity, persuade to go in for sports, respiratory gymnastics, because always during our visits to pulmonologists, we provide some patient brochures and leaflets, and there are patients who are very much interested what sort of pulmonary gymnastics they can do, and we're always happy. We are always happy to talk about it, and we're always happy to give such instructions. So that's why I'm calling you to that. Thank you very much for your attention. Muted. Thank you very much. Thank you for a fantastic presentation. And we have already several questions about that, about the type of pulmonary rehabilitations, about different machines that could regulate pulmonary resistance, but all questions would be at the end. And due to the changes of the agenda, I again have to give the floor to myself with another presentation, physical exercise with heart failure patients. So within a second, I will initiate my screen sharing, and we will talk about the final effect for many patients with CHF. So traditionally, CHF, it's a quadruple treatment. This is RNA and antagonists of mineralocorticoid receptors, beta blockers, etc. And traditionally, these are diuretics. But what about physical exercise? Can physical exercise influence the prognosis of patients with heart failure? And as well as in the previous presentation, here it is very disputable. Unfortunately, developed CHF gives us not so much space for maneuver, but let's go step by step. When we recollect CHF, so if you want to be very responsible for the patient management, we start creating the pyramid of treatment, so-called pyramid of treatment. And the basis of this pyramid are the several points. So this is the management of body mass index. So we should not miss the decompensation. And it is obvious that the body weight is increased 1, 2, 3 kilos for several days. These are edemas, and we are increase the dose of diuretics, and we remember that, and we teach patients that. So this is also the diary for pressure, for everything, and it is done not for the doctor because we cannot read it, but it is done mainly for the patient to have very conscious attitude about the pulse and pressure. This is monitoring of edemas, and definitely this is vaccination, and definitely this is respiratory gymnastics and physical exercise. Why is it so important? Why I'm doing the accents to the pulmonary gymnastics? Because pathological process in CHF could be seen in whatever. So we're speaking about the vessels, we're speaking about the kidneys, about the dilatation, about arrhythmias, but we forget that pulmonary gymnastics, which is recommended to all the patients, has one very serious problem in the basis, not the lung injury, but diaphragmal injury, so-called phenomenon of diaphragmal depletion. Please recollect your student, yes, your daily practice. Remember autopsies of patients who died from trauma. Diaphragm should be muscle, and now let's recollect the autopsy of the patients died from chronic heart failure. So this is depletion. It's very thin, very rigid, and reminds the piece of cloth, gray color, because with the increase of the functional class, we see the change of the muscle mass. Muscle mass is reducing, and connective tissue is increasing. There is more fibroblasts and fatty inclusions, and we published the series of publications about it, and we see with each next functional class, it's especially dramatic on class 4, functional class 4. We see changes when we speak about the muscles, and it's not a muscle anymore. It cannot participate in the excursion of the chest. In histology, we see this muscle is totally different from even first functional class. If we go deeper, if we see maximum thickness of diaphragmal dome, more muscle tissue, the thicker is the dome, the less than it's thinner, and then it's quite elastic. It's muscle, still muscle, but not elastic anymore, which is not performing any proper functions. And definitely the parameters are suffering inhale pressure, exhale pressure, the capacity to dilate the chest. So all these parameters are dramatically reducing, and hypoxia is also increasing. It is important to mention that number of fibroblasts are changing in the connective tissue, not only in the diaphragm, but also in the soleus, in the femoral muscle, because participates in the venous return. Also in the whole muscle carcass, and also in the muscles responsible for the breathing. And if diaphragm is so dramatically changes, what about gymnastics? Would it give the results? And if yes, then when? The answer to this question is very simple. Yes, it gives the power of inhale would be changing. So PIT is a control group and IMT is the investigational group. Yes, it will be influencing, because regular respiratory training would significantly increase the capacity to inhale, capacity to oxygenation and blood saturation and oxygen saturation and oxygen use, because it would be normal breathing. And this is not a single effect. It's very important that we train the patients, and already in 10 minutes, we see very good results, which are different from that. And instead of that, if we give it close lips and several breathing exercises during the day, so we'll give fantastic results. And then the excursion of the chest, the inhale exhale power would be at the higher level, sustainable at the higher level, versus those who did not train, and it gives them better saturation of oxygen and consumption of the oxygen, and it would be persisting after the training. So they believe that 2-3 respiratory trainings within 10-15 minutes each per day are optimal. And it's important to mention that if your patient is of a very high functional class, you cannot start these trainings in standing position, only in sitting position, comfortable position, because patient may experience dizziness. But patient should go for respiratory gymnastics. And if a patient wants to use pranayama or some other Eastern techniques, the results would be equivalent. So it's not important which type of respiratory gymnastics is appreciated, but everything that creates training for breathing and resistance during inhale and exhale would give positive results about the diagram. And definitely if it is combined with walking, where there is a training of gastrocnemius muscle, then the result would be double better, twice better. But let's go from respiratory gymnastics to the comprehensive physical exercise for the patients with heart failure. And now it's a very difficult question, because we see that the biggest study in this area, HF Action, that followed patients for 3 years and made an objective to understand how reduced or preserved ejection fraction could influence and to what extent physical exercise could change the prognosis of our patients. And unfortunately, it was not the best expected result. Yes, mortality and hospitalization in the training group were reduced, but only when there was adjustment for the additional risk factors. So when we take the population in general, no, we don't see result. But with adjustment, yes, we see some reduction. A little bit more optimistic are the results when we try to look at mortality and physical training. So in fact, almost immediately, if we look at that, so there is no difference in resultativeness. So group A, less than 12 months, group B, more than 12 months of training. But here we already see particular improvements. Less than 12 months follow-up, nothing. But longer than 12 months follow-up, we see particular improvements of the effect, progression of the effect about our patient. Let's move deeper. Let's try to think it over. And what can we obtain with trainings in other endpoints? How we can move on? And again, less than 12 months A and more than 12 months B, less than 12 months B. But again, the hospitalization for heart failure is reduced. HHF reduced, hospitalization because of heart failure is reduced. And this is a trend to reach statistical significance, not in all the studies, but with big power, statistically powered studies, we see a reduction of hospitalization for these patients. And definitely we see the improvement of the quality of life. Quality of life is changing regardless if it is less or more than 12 months of follow-up, we see improvement of the quality of life, and this is obvious. Then there is a question: if we give the reduced ejection fraction, if to be precise, it was less than 45, and then in the middle of the intermediate fraction. So what about preserved ejection fraction? So patients are more preserved there, and there should be better results. So let's try to find out. If you look at this group of patients, we see particular improvements, clear improvements. And what did we assess? Quality of life of patients with a preserved ejection fraction, with physical exercise, and then we see exactly the same improvement of the systolic and diastolic, a little bit of improvement of ejection fraction, improvement of oxygen consumption, which is clear. So this is upper chart, which is shown here. And we look at the bottom one, the quality of life, exercise better. That means we see that exercise gives a better results. Then over here, the improvement of diastolic function, then systolic function, and ejection fraction. So summing up on the preserved ejection fraction, the training did not lead to clear statistically significant improvement of systolic and diastolic function, but gave the trend to the significance. But in any case, they improved quality of life of our patient. They also led to the improved of the peak oxygen consumption, led to the tolerance, increased tolerance to physical exercise. And that's why they needed with reduced and preserved, even hospitalizations are reduced. And in both cases, it is important. So besides respiratory gymnastics, we speak about comprehensive training. So it also gives the results. The most important, which exercises are recommended to our patients? What are we talking about in this case? What I show you later on sounds like torture, but it's not like so. So they believe that even bedridden patients can perform So stamina training, it doesn't mean your patient would do lots of repetitions and do it one after the other. If patient can do it, that's great. But this is actually effect of particular groups of muscles that could perform your patient. So what is important? In all the studies and European recommendations, there is an accent that it's good to do with the control of VO2, either special devices or portable devices can measure that. So oxygen consumption should be kept within 50% range from the maximum until your patient is able to perform exercises at least 10 to 15 minutes. Which exercises? Any movements with arm, bicycle, sitting or lying, maybe some gymnastics, or if it's a working patient, it could be even more comprehensive approach. As it is 15 minutes, then we can increase oxygen consumption up to 80% of maximum, duration up to 30 minutes. The objective is 60 minutes or 5 times a week, a radical improvement of quality of life. So what is training for stamina? So any bicycle, gymnastics, skipping, whatever. So many other options. So no matter what your patient is doing. Then second one, let's say for the younger patients with the add-on of intervals in trainings. We start the same. The interval of peak load, what does it mean? So that means standard training, then patient is getting faster. We speak about CHF, not longer than 10 seconds. So we should do it not faster than once in 5 minutes, but then patients is more or less reliable. We can increase oxygen consumption duration up to 15-30 minutes and peak interval up to 30 seconds, not longer. High intensity and low intensity, but what is a must? Short interval of high intensity, and then more or less relaxed 5-10 minutes, and then repetition of the physical exercise. And there is a third option, power training. Many patients prefer them because they're much clearer. And then we should not control VO2, but what we should control is weight. And then using bioimpedance, the percentage of muscle mass is also regulated. If you performed low intensity exercise, that's 5 to 10 repetitions, moderate up to 25, and the high no more than 15. 2-3 times per week is more than enough. And this is increasing muscle mass. And if you reach it, then we understand that like in many others, one of the problems with CHF is a loss of muscle mass. That's why it's very important to combine. And for many patients, it's recommended to combine today it's a power, then stamina, and maybe some aerobic one. Let's say Scandinavian walk, Nordic walk, 10,000 steps a day. That's ideal purpose. And that's it. That's it. All that is, it gives us combined results. So let's sum up. So the first thing when I'm talking about physical exercise, this is respiratory gymnastics, 10-15 minutes using all the techniques possible. 3 times a day, ideal results. If we add on stamina training, then power training or interval training, then continuously increasing from 5 minutes to 10 minutes, and then later on. So altogether that preservation, let's say, of the diaphragm, then tolerance to physical exercise, and in perspective in 1 year, it could influence the hospitalization rate. Because of that, but no doubt what could be improved is the quality of life of our patients. Thank you very much for your attention. And I think that was the final presentation for today. And we had some recent changes. Unfortunately, Ria Nailivna will not be able to make her presentation, but hopefully for the next congresses, we will try to change that. Let's move to Q&A session. And we have several questions already. So I announced so we speak about the practice, resistance to inhale or exhale in bronchial asthma. What is better? Thank you very much for the question. Very good question. So if a resistance at exhale, it's mainly for the patients with broncho-obstructive pathologies, and also for the patients where it's very difficult to cough out when there is a sputum or bronchiectasis, let's say, and it's helping, very much helping and facilitate bronchi extension and better coughing out. Then training on the inhale, that's mainly approaches that help patients who were hospitalized for quite a long time, let's say with severe pneumonia or post-COVID, which is very relevant even now. To improve the volume of the lung tissue, because their muscles were suffering because they were quite a long time in the hospital and they were very severe patients. Then there was another mistake of the patients. If you take COVID patients, they should not use approaches in the exhale, only inhale for the stimulation of the activity of the breathing muscles. And what muscles are involved? Mainly muscles in the diaphragm, in the, there is another influence. So if it's resistance on exhale, we get influence the lumen of the bronchi, and it facilitates better discharge of the sputum and better bronchodilation. If lung was damaged in big volume in COVID, so we were very much afraid of the damaging of the lung tissue. And we couldn't use such approaches. That's why they're different. Muscles are the same, but the influence of bronchi lumen and the sputum, which is there, is quite strong. Can we provoke any pulmonary hypertension by that or something similar? Well, no. Okay, thank you very much. Mikhail, question to you. Today in the fast session, we spoke about CKD, and there was a question about the loss of albuminuria and loss of protein in those who go in for sports. And the same question in a little bit different form sounded now. So what to do? What to do with physical exercise if we know today that the physical exercise could influence loss of protein and albuminuria? Well, Alexander, I want to say that this is not the albuminuria that belongs to the persisting albuminuria, and this is not albuminuria, it's a criteria of chronic kidney disease. Well, quite naturally, there is tachycardia. It's not related to paroxysmal or chronic tachycardia with a relaxed situation, with some myocardial disease or other systems of myocardial. So this accidental, so that means albuminuria, it's like an episode. This is physiological albuminuria. So you take a young person and this is chronic kidney disease. We could recommend physical exercise here, and with the physical exercise, it demonstrates increasing of albuminuria. We are not afraid of that. No, we're not afraid of that, because the criteria of diagnosis, we use albuminuria, which is taken according to particular requirements to the tests. And among these requirements, one of them is a resting condition before the test. So this is basic protein loss, which is pathological, and this is what we have to pay special attention to. What happens to physical exercise, psychological load? Well, I think albuminuria can be increasing with the protein load, and at certain time there was very popular test which was called a test for functional kidney reserve. You can remember that. So they identified GFR, they gave some food, and then there was some growth in GFR after meat intake. So that's so it's not a future for arterial hypertension. Physiological reaction of the organism. So the audience, after the exercise in the gym, it could be albuminuria, but it doesn't mean anything serious. And also I wonder, so I remember marathon runners, because it's more than 100 kilometers without stop. I think they should have very severe albuminuria after such a race. That's very interesting comment, what you mentioned now. And people who run marathon, and there is a program Healthy when they run 20 kilometers or more, but because this is surprising thing, because lactate hydrogenase is growing, and in some of them myoglobinuric changes are seen. So myoglobin is coming in the urine, and level of creatinine is growing, almost all of them in metabolic acidosis, and the compensated one, but nobody is taking them and treating them with sodium hydrocarbonate, etc. That's absolutely physiological reaction organism in response to the intensive physical exercise. Any comparison of studies in the trainings, any difference from your point of view? I think it's difficult to answer, possibly not. The difference most probably is in the training itself that we are talking about, aerobic, non-aerobic, I think somewhere here, but in the closed one, I don't think. I think the content of oxygen in the air is always stable, indoor or outdoor, it's almost the same. Yes, you are right. The other thing is that so that's the only condition that could give us a difference. the lifestyle is not ideal. So is to approach ideal lifestyle. Well, you can look philosophically at that. The problem of dyslipidemia would give us significant reduction of the quality of life later on, and probably it's easier to do the prevention than to treat consequences. In the recommendations, it could be standard set. This is absence of smoking. This is food rich with fibers, then regular physical exercise, and preferably daily, and younger than 40 every day, then walking, and here it's reduction of cardiovascular risks, starts from 6,000 steps. About alcohol is very disputable because there is French paradox. So they had fatty food, but regular daily wine. They reduced MIs and ischemic events, but what they had is a higher rate of atrial fibrillation and arrhythmias. So both is bad, both is bad. So in any case, misuse of alcohol increases the additional risks of cognitive dysfunction and also oncological risks. So probably we need to minimize the amount of alcohol. According to Canadian recommendations, 30 units per month in English and American. So 10 milliliters of ethanol. So this is about 9 units. How to calculate the load for patients with morbid obesity and paroxysmal atrial fibrillation who are taking anticoagulants, beta blockers, metformin, stopped and stopped smoking. There is chronic kidney disease. Please comment on that. We should start from very moderate physical exercise. So maybe Nordic walk. So that's natural movement of muscles than in walking. At least 10,000 steps a day. And when they're moving quite confident with Nordic walk with sticks, 10,000 steps a day, then increase the duration. Plus respiratory gymnastics. Probably I recommend this. Yes, that's it, what I can say, colleagues. Would you like to add on something? Maybe some more comments? You're welcome. No, I think you covered that quite completely. So such procedures could influence on the ACL and PCL. Hemarthrosis could be seen in such patients, anterior cruciate ligament and posterior cruciate ligament. That's why swimming would be good in this case. Yes, totally agree with you, totally agree with you. After being in the cold water, after each sport, the biggest release of ghrelin after swimming, and definitely swimming could be recommended here. High sensitivity CRP. So is it the same like CRP and high sensitive CRP? Standard CRP cut point is 5, sometimes 10. And this is inflammation in general. But if you want to get deeper inflammation, background inflammation, then probably we need to use, let's say, high sensitivity C-reactive protein, where the cutoff is 1, 2, 3, sometimes more than 2, but very frequently 1, 2, 3. Everything is higher than 1. It's already risk zone. The normal range is 0.5 and lower. Everything which is higher than 3, this is background inflammation. And if it is atherosclerosis, I said this is a very good question with such background, because when we speak about For the first time, we are not highly trained, but there is a damage of the muscle. So there is a change of high sensitivity protein. When they go to particular plateau of trainings, this effect could possibly disappear, but at the very beginning, it could be increased inflammation, etc. Marina, how frequently patients with COPD should perform respiratory gymnastics? And could it be somehow combined with the continuous smoking or not? What do you think? Well, funny question. So we discuss it. Sometimes patients can have stress, etc. But smoking, definitely we should stop it. Not everyone manages. So if patient cannot stop smoking, then they have to be treated with the drugs and actually follow respiratory gymnastics. Because what can we do in this case? Because the rest is there, physical exercise and inhaled and etc. But everything depends on the severity of the patients with COPD. If COPD is severe or very severe, then these are patients with very severe shortness of breath and for the first time, 10,000 steps for COPD, it is the same. So patient can move the pace he or she likes. And they do this 9,000 steps comfortable for themselves in the pace they needed. But if we speak, that's about 20 minutes per day. If we speak about the training, so if I said before, let's say resistance to the exhale, then that's about 20 exhales in the machine, and then couple 2-3 days we do this type of respiratory gymnastics here. Let me add on that the train itself should be kept very clean, and we need to wash it after each use to avoid superinfection here. So that's important. So for patients with obstructive pulmonary disease, very frequently patients with CHF are recommended until the mild tiredness. So what can you follow this recommendation? So it's recommended when there is no opportunity, when we cannot manage VO2, and we don't have it anywhere in this except special centers. So mild tiredness, that's 50 to 60% when we reach peak use of oxygen. That's the area where we need to start. So when the patient cannot perform the load, at least 15 minutes, but then we can reduce intensity. But I wouldn't recommend to any patients with CHF, especially in the late functional class, to go to some more heavy exercise, or let's say to dizziness or loss of consciousness. It's impossible. It's not allowed. Statins, using of statins, risk of myopathies and rhabdomyolysis and physical exercise. That's a very good question. Patients with muscle weakness should be very cautious about physical exercise because they could increase symptoms. And in this case, we need to follow algorithm to stop treatment. If you see such symptoms, to stop the symptoms with statins 3 to 4 weeks, but not longer than that. Then restart of treatment in 80% symptoms will gone. If symptoms are not gone, then in this situation, we need to change the statin, we need to change the dose. Then symptoms are persisting and only then refuse from statins. So that's the question not about the risk of training, but the question is about persisting compliance to the patients with the onset of muscle weakness and the administration of statins. Professor Batyushin, CKD3B, atrial fibrillation, CHF, what should be the load and how frequently can we recommend it? In such situation, we can recommend walks, long walks, again, swimming and bicycle. Well, moderate, quite mild loads. In my presentation, I already told you there are 3 categories of the patients. I would refer this category to the sedentary patients. And then the loads, you remember, 5 times a week, 20 minutes each. If it's walking, about 3,000 to 5,000 steps for the beginning. So we should start from something quite achievable. And about previous question, you gave answer about rhabdomyolysis. I have to say rhabdomyolysis is the most frightening here, that the organ where it's hitting kidneys. It is called myoglobinuric kidney, and all the problems come from here. So if your patient is in the gym, if there is no contraindication from the cardiology, it is recommended alternate different loads with a fluid intake with proper volume, because myoglobin, in any case, if there is myalgia phenomenon and there is rhabdomyolysis, then you should remember that this is indirect feature of rhabdomyolysis. Still, it's with physical exercise, and creatine phosphokinase is growing. So with fluid intake, you will eliminate this myoglobin from kidneys without letting it glue into the cylinders with the formation of blocking channels and the development of myoglobinuric kidney. Thank you very much. Well, unfortunately, the time for discussion is over, and traditionally we will answer all other questions in our Telegram channel. Thank you very much for the attention to this session. Many thanks to all our speakers and participants. Thank you very much for your interest, for your question, for your interaction, and stay with us. See you later at the next symposium.
Distinguished colleagues, good evening. This is the evening session devoted to issues of differential diagnosis, definition, and the treatment of patients with anemia. Today we'll be talking about normochromic, hyperchromic, and hypochromic anemias. There are lots of different classifications of anemia. Which classification is better is difficult to say in clinical practice. Today, anemias are divided in terms of normochromic parameters, normocytic parameter. These definitions are widely used. Anemia is the condition which can be in a patient for the rest of his life. About 40% of all patients with internal diseases can have normochromic syndrome. It can be persistent, it can be easily controlled, or vice versa. It can be persistent, it can be resistant to therapy conducted. In some cases, we cannot understand why anemia develops. In some cases, we cope with anemia quite easily, like in case of arterial hypertension or angina or tumors. Anemia is an interest for us and for our patients. They understand what we're talking about, despite the fact that anemia can be a lesser severe condition than oncological pathology, but it may be a condition as a marker of severe diseases. Patients are very well interested in problems of anemia, in issues related to controlling this condition. So today we'll be talking about our problems of anemia from the point of view of diagnosis, classification, definition, differentiation, and management of patients with this pathology. Since you're truly is the moderator of this symposium, I would like to give the floor to myself and to start with the issue of normochromic anemia. I am absolutely positive that our audience is very well aware what is meant by normochromic anemia, but nevertheless, I'd like to remind you that there might be different definitions of this condition. Normochromic anemia is the reduction of blood hemoglobin characterized by the normal level of hemoglobin inside the erythrocyte and the normal size of red blood cells. So here we're talking about a reduction in the number of erythrocytes. Hemoglobin contained in erythrocytes has a normal concentration per 1 unit of erythrocytes. So normochromal anemia is when MCH is from 27 to 31 picograms, hyperchromia less than 27, and hyperchromia more than 31 picograms. Besides that, we take into account the size of erythrocytes. A normal erythrocyte, a normocyte, has the size from 7 to 8 microns. You can see it in the middle here. And there is a microcyte, 5 to 6 microns, macrocyte, 8 to 12 microns, and megalocyte. That's a huge erythrocyte with a size of more than 12 microns. And in some cases, this is not the form of erythrocyte, but there is the fragment is
It is located in the interclinical. So MCV, this is a volume of erythrocytes. MCH, this is hemoglobin in one specific erythrocytes. And MCHC, this is the average concentration of hemoglobin. And in the first case, hemoglobin is multiplied by 10, and we delete two erythrocytes. A normal volume is about 80 to 100 microns. In the second case, hemoglobin and the grams per deciliter or liter, but don't multiply for 10, and then we divide into erythrocytes, and we get 27, 27, 31, 34 picograms. And in the third way, hemoglobin is divided to hematocrit in order to identify the average concentration of hemoglobin inside one erythrocyte. And we will speak about the normocytary normochromal anemia, and MCV and MCH and MCHC. All three parameters will be normal, absolutely normal. So normochromic anemia, they split into two categories. First is the category of anemia due to the reduced production of erythrocytes in the bone marrow. And this is so-called hyperproliferative or hyporegeneratory anemia. So you can use this term or the other term around. So in fact, there are some more terms here, but I think that's the most popular. So in the second one, normochromic and normocytary, this is shortening of life of erythrocytes for the production of the bone marrow. So this is hemolytical one. Maybe some of us can say, you know, I saw hyperproliferative anemia and also hyperchromic anemia, and I saw hemolytic anemias and also microsaturated anemias, let's say microcerocytosis of Minkowski-Shaffer. Well, you're right. Anemia classification is quite rich, and this is, quite, let's say, conditional. And very frequently, the forms of anemia that we see can include components from very different definition and classification. And so ideal classification and what we speak about within this presentation and the other presentation. So most frequently, these are variants which are frequent in the clinical practice. And as soon as we're trying to identify them as normochromic or hyperchromic or hypochromic, then this is how we are trying to identify their particular common pathogenetic mechanism of development without missing with other lines of pathogenesis and without mixing them with different variants of formation of anemic syndrome. So hyperproliferative or hyperregeneratory anemias. So here we see three main groups of anemias. This is anemia with a reduced production of erythropoietin, anemia with reduced sensitivity to erythropoietin, and last but not least, anemia as a result of bone marrow failure. So anemia with reduced production of erythropoietin, definitely this is anemia in CKD, that's for sure. And as an example, I will give it to you in much brighter explanation. So that's a bright example whether the deficiency of erythropoietin production is a dominating substance in terms of pathophysiological orientation and creation of anemia. The rest of the substances and components, they are more recessive. They are not dominating in the creation of phenotype of this anemia. Anemia in endocrinic pathology, hypothyroidism, adrenal failure, and I can give you some examples of such anemias. Anemia in depletion, in cachexia. The second one, and this is anemia with reduced sensitivity to erythropoietin. This is anemia in chronic diseases, which is called like this, also anemia of chronic disease. And in international disease classification, we have particular code for that. And by the way, hematologists very frequently advise us the following: put here in the diagnosis form, diagnosis, not a renal anemia, but anemia of chronic disease, because it's not just the deficiency of erythropoietin production production in patients with kidney disease, but also deficiency of absorption of iron, and deficiency of cyanocobalamin, and deficiency of folic acid, and other components which are deficient. For example, uremic toxicity is important in terms of influence of the bone marrow and inclusion of severe achristic mechanisms and other deficiencies of other microelements in the bone marrow. All that can create deficiency of erythropoiesis, and this is how creates the combination of reasons for the development of anemia without limiting of just erythropoietin deficiency. So next reason here, this is anemia of infiltrations in the bone marrow. So this is miliary tuberculosis, sarcoidosis, leukemias, Gaucher disease, etc. Anemia in the bone marrow failure, aplasia of bone marrow, then partial red cell aplasia, and these erythropoietic anemias. And the second session here, this is hemolytical anemia. Now, several examples, as definitely we cannot cover everything within 20 minutes presentation, but nevertheless, we would be happy to provide some examples and put some dots over the eyes for the normochromic anemia and for the diagnosis and for the management of normochromic anemia. So I will try to do it within a few minutes. Anemia with reduced erythropoietin production. This is CKD-associated anemia. The reason here is uremic intoxication that in any case influences erythropoietin secreting cells, and also the processes of systemic inflammation, malnutrition, cachexia, and also protein nutritional deficiency. But these are factors which are associating this anemia, which are creating the severity of this anemia. This is the factor which is creating this anemia. This is the death of cells in the tubular epithelium, which has capacity to produce erythropoietin producing cells. I remind you that from 50 to 70% of the total erythropoietin is secreted in kidneys. And let it be glomerular nephritis, amyloidosis, or tubular interstitial nephritis, or nephrosclerosis of different genesis. So in any way, multiple pathological processes, although it was quite individual etiopathogenesis, but they have universal effect to these cells. They simply die. And unfortunately, there is absolute deficiency of erythropoietin, and as a result of that, anemia is done. We have to say that anemia in patients with CKD is an independent, absolutely independent risk factor for the hospitalization of patients with cardiovascular complications and also development of the terminal stage of kidney disease, and also mortality of these patients from all reasons, all-cause mortality. So if patient on hemodialysis with chronic CKD has anemic syndrome, that means the patient would live shorter, life expectancy would be shorter. That means the patient could have more cardiovascular complications. And as I said before, pathophysiology of renal anemia is not limited exclusively with the disproduction of poietins. So this is reduction of survival of erythrocytes with the uremic intoxication and effect on the membrane erythrocytoid cells. This is also reduction of hepcidin release with uremic intoxication. On the one hand, acute phase protein, but on the other hand, a protein that plays a huge role in the ferrokinetic processes and also in the development of anemia. This is blood loss. In hemodialysis, patients are losing about from 200 up to 400 milliliters of blood. This is chronic hemorrhagic anemia. And these patients very frequently take blood for different tests. And these patients are losing part of blood with extracorporeal dialysis contour, and also it is related to the fact that the number of blood losses is due to the development of hypocoagulatory bleeds, nasal ureter bleeds with intoxication. What about the treatment? Treatment of anemia in the kidney disease, it is based with the treatment of main disease, and the slowing down of the progression, and this is the basis of the effective treatment of the anemia. Besides the control of nutritional status, then the use of iron in case of iron deficiency, And the basis of treatment is the use of the drugs which are stimulating erythropoiesis, correction of the folate deficiency, B12 deficiency, the use of new class of treatment, which are inhibitors of prolyl hydroxylase. So these are the factors that are blocking the degradation of hypoxia inducible factor that actually in general is a very powerful stimulator for production and the precision of endogenic erythropoietins in the organism. Erythropoietin stimulating agents, they're very different, very different. What we frequently use in the real practice, these are poietins, alpha, beta, delta, etc. Then darbepoetin and other drugs are used not so frequently, but nevertheless, they're also available. And I would like to say that unlike healthy volunteers, let's say for the male, the lower level of hemoglobin is 130 gram per liter, and for the female, it's 120. For the pregnant, it's 110. Then kidney patients, they are different within their objectives. So this is how increasing the level of hemoglobin in patients with renal pathologies, we have to stick to the range from 90 to 115 gram per liter. And if you take Russian guidelines, then this is 110, 120 gram per liter. But why so, you will ask? And I can tell you that if the level of hemoglobin would be higher, then it would lead to the increased risk of thrombosis and cardiovascular complications. Exogenic erythropoietins, they are capable to increase the level of blood pressure, and they create resistance to treatment of arterial hypertension. That is why the target level of hemoglobin is normally limited with the figures of 115, 120 gram per liter, and the upper limits of this target level in patients with a kidney injury. So the next type of anemia is due to reduced production of erythrocytes, and this is anemia of endocrinic pathologies, and specifically hypothyroidism, hypogonadism, hypopituitarism. As an example, I would like to give you hypothyroidism. This is very actively used pathology. 43% of adults and 65% of children with hypothyroidism had features of anemia. The mode of action, no stimulation for the development of erythroid colonies with thyroid hormones. Manifestation is normochromic, normocytory anemia, and normally with reticulopenia, hypoplasia of erythroid origin. And very frequently in blood, we could see this type of dysmorphic erythrocytes, so-called acanthocytes. Please remember that cancer-cytosis could be hereditary. This is autosomal recessive pathology, and this is acquired cancer-cytosis. And if you see it in the peripheral blood, then this is it can be with high probability hypothyroidism. The treatment is replacement hormonal treatments with thyroidal hormones, and that would be the basis of treatment. Anemia of chronic diseases, autoimmune diseases, infections, tumors, cardiac failure, etc., etc. This is reduction of the life expectancy due to erythropoiesis and reduced production of erythropoietin. Normally, such anemias are characterized with normocytory and normochromia. Normally, they are not severe, hemoglobin 80, 100, and let's consider that. So the second class of anemia is the other one. So on the left, we see intracellular hemolysis, and here in the process of degradation, we see non-direct bilirubin. So this is the reason of why we have to do it, hemolytic or intracellular jaundice. And then the other type of hemolysis, this is erythrocyte, and is not capable to do it with macrophages.
This type of hemolysis is called intravascular. The fraction of free hemoglobin increases. There is a reduction of haptoglobin, and there is a high level of hemosiderin. In this situation, urine can be tea-colored, but there are immune hemolytic anemias. There can be hemolytic anemia in case of heart pathology of large vessels, microangiopathic anemias, anemia due to the poor structure of the membrane of erythrocytes, such as paroxysmal or night amenorrhea, called also nocturnal. This pathology right now can be treated much better because this pathology is considered as complementopathy, and we can effectively treat this anemia, especially when we're talking about heavy metals or immunotomy or autoimmune, when we have an antibody against the hemoglobin and its structures, and they can be heteroimmune or gapten when on the surface of erythrocyte there is an antigen substance which can cause an antibody attention, or isoimmune, such as hemolytic disease of neonates, post-transfusion and post-transplantation hemolytic anemias, and transimmune, the transplantational or transplacental anemia, which is conducted from the mother to the child. Thrombotic microangiopathy is a separate medical course within the 6 year of study of students. This thing is not studied. Also DIC, well, starting from HELP syndrome and severe preeclampsia during pregnancy, all the way to the hemolytic uremic syndrome, HUS, and atypic hemolytic uremic syndrome, and C3 dominant glomerulopathy within the frame of the group of different pathological processes. But one way or another, we're talking about capillopathy, we're talking about the formation of thrombocytic clots, and we're talking about the mechanical hemolysis, as you can see it here. As for TMA, there are 4 major types of thrombotic microapathies: HUS, STAT, HUS, thrombocytic purpura or Mashkovich disease with Adams 13 involved, and the second form of TMA, like those which occur as a result of the action of cyclosporine or anti-EHF therapy, or patients with HIV infections, or patients who have pregnancy. This type of hemolytic anemias is accompanied by thrombocytopenia. It is accompanied by the appearance of cytolysis markers like lactate hydrogenase, galactoglobin level drops, and you can see those pieces of erythrocytes. And autoimmune anemias can be primary and secondary as a result of lupus erythematosus, or they can be classified by the type of hemolysis. Like, for example, there may be mixed variants and serological properties of autoantibodies with incomplete thermal agglutinides, with two-phase hemolysins, and so on and so forth. According to the recommendations of the National Hematology Society, the reduction of the level of hemoglobin in case of autoimmune anemias is more significant. Here it says the 26 to 36 grams per liter, but in fact, it can be 60 or 50 or 70, but it's not 80 or 90. Usually, these are more significant parameters in the drop of hemoglobin. Remember, here there is no hypergeneration. Well, dying erythrocytes will be replaced by reticulocytes. That is why these patients, as a rule, usually have reticulocytosis. So the sign of the hemolysis of erythrocytes, hemolytic anemia, is that it is accompanied by an increase in the level of leukocytes in blood. That's very important. Finally, inherited anemia as a result of the membrane defects, membranopathy, and I have already given this example of inherited microspherocytosis. It can be ellipsocytosis, or it can be macula phenotype. The enzyme defects in the synthesis of glycolysis, or there might be compact spread of this pathology, but due to some geographic peculiarities or the deficiency of metabolism of different enzymes, such as enzymopathy. Here you can see the cell-like anemia in the Russian interpretation, as you can see it here, and different M hemoglobins forming anemia such as A thalassemia and other diseases. Dear colleagues, within this brief presentation, of course, it's difficult to touch upon all issues of problems of normochromic anemias. I hope that I was able to cover this particular problem from different angles. And now I would like to give the floor to my colleague, Professor Alexander Arutyunov, who will be speaking on other types of anemia, which are accompanied by hyperchromia because of microcytic processes, but hyperchromic anemia is different in terms of pathogenesis and clinical manifestations, and even the issue of management of such patients as compared to normochromic anemias. Alexander, are you ready? Yes, I'm here, and I'm ready to speak on this topic. Dear colleagues, let me share my screen. And in this presentation, I will try to focus on the role of therapy in management of patients with hyperchromic anemia. I will try to show what the results might be, how the events can develop depending on microcytic anemia. First of all, when we are saying that the patient has anemia, we must understand there are specific patterns of specific types of anemia, and especially when a patient comes to see a therapist. Well, anemia depends on age. We can see the situation after the patient is after 70, before 70, there is anemia in 15 or 16% of cases, but after 70, we can see there is a surge in the cases of anemia. Here we're talking about all types of anemia: iron deficiency anemia, hypochromic, normochromic anemia. If we move further and ask the question, what should be the ratio between men and women, we can see the gender distribution. You can see that the distribution is equal, but among women, there will be more people with intermediate anemia, and there will be a lesser number of women without anemia. This story with comorbid conditions and anemia is of particular interest. When we use anemia as the base point, we should look at what other comorbidities the patient has. Professor Batushin talked about normochromic anemia, but we can see the highest percent of anemia was in patients with chronic kidney disease. The second place was taken by chronic heart failure that has a more etiological reason for the development of anemia, from CHF to malabsorption to the intake of specific drugs. Well, other comorbidities: diabetes mellitus, hypertension, hypothyroidism, which can be the reason for microcytic anemia, malignancy, rheumatological diseases, liver diseases, CAD, COPD. So number one is CKD and CHF. Well, the goal of the therapist is to detect anemia and to make a hypothesis about the reasons for anemia. As for normochromic anemia, a lot has been said about it. I am talking about hyperchromic anemia. When we are hearing this term hyperchromic anemia, we're talking about folate deficiency anemia, and B12 and folate deficient anemia can be normochromic in nature. So it's not that not just the patient who has the hyperchromic condition. And here I will focus on B12 and to a lesser extent on folic acid because we understand that a large number of drugs that are routinely administered to our patients, like epidemiological drugs, can lead to a shortage of B12, thus leading to anemia. But let's move further. Question number one and task number one. If, well, B12 and folio deficient anemia can lead to normochromic anemia, well, first we do the diagnosis of normochromic anemia, but we're talking about just a differential diagnosis. We're trying to understand if this patient has a chronic kidney disease, and naturally we should calculate GFR. We assess concomitant conditions, and I would like to remind you that when we look at different stages of CKD, we ask a question, how often anemia occurs? We can see that 25% of cases have mild anemia, even at the first or second stage of CKD. At stage 5, the occurrence is 85%, but the more significant anemia, when hemoglobin is less than 100, occurs quite rarely. In 5% of cases at stage 2 or 3, 10 to 12% at the fourth stage of CKD, and can achieve 25% at fifth stage of CKD. If we see that the patient has normochromic anemia, we think that there is a B12 deficiency, and you can see CKD stage 3 or 4. This is linked to the kidney, but not to the early deficiency of B12. There is another study where the WHO criteria were used. You can see CKD 1 to 12, CKD stage 3, CKD stage 4 to 5, and you can see WHO criteria. The prevalence rate increases, but starting from stage 3 of CKD, the anemia becomes very well manifested. If we see anemia and CKD do not reinvent the wheel, it's probably normochromic anemia, even if there is a B12 deficiency. Since we touched the issue of differential diagnosis, let's just dig deeper and look at the mixed group for development of anemia. This is a patient with chronic heart failure. Why do I mention such patients? If we draw anemia at the bottom of the slide and what factors can exacerbate anemia or lead to its development, first I should say that patients who still do not have chronic heart failure are anticoagulants and anti-aggregate therapy. That means the loss of iron, and a ASCENT study testifies that such patients has a risk of reduction of cardiovascular diseases, but the risk of hemorrhage is increasing by 29%. The next stage leading to anemia is when specialists try to avoid the risk of bleeding, adding PPI, proton pump inhibitors, and there is another problem. Proton pump inhibitors lead to the deficiency of B12, and the hyperchromic anemia develops. So let's move further. The patient has CKD developed, and that's a polyethiological mechanism for development of normochromic anemia due to the deficiency in the synthesis of erythropoietin. Well, in this case, anemia grows, and the patient has heart failure, which due to the malabsorption syndrome, we remember that in this case, the intestinal wall is involved. We have the iron deficiency anemias together with normochromic anemias, and that reduces the quality of their life. This is malabsorption, and we have one reason for development of hyperchromy, 3 reasons for hyperchromy and for normochromy. Can we say what particular anemia these patients have? Only after some examination. Well, we can do this by excluding bleedings. Well, but can this patient have iron deficiency and normochromic anemia? The answer is yes. So these patients must be subjected to specific examinations, not just, well, the determination of level of hemoglobin, but also the ferritin and iron levels in the serum and so on and so forth. But if we think that our patients have hyperchromic anemia, B12 deficiency, and folic acid deficiency, we have two types of reasons, or even three. The more apparent reasons, such as alcohol abuse, a large number of patients who are vegans on the vegetarian diet, and this has an impact on GFR, also pregnancy, and of course, patients who are vegans during pregnancy, Crohn's disease, well, stomach resection, HIV infection, but we must remember that there are other rare reasons, and I can just have one slide on this subject, but also there are people age 25. The reason was described some time ago. You can see nitrous oxide, which is very widely used as a recreational gas, and this leads to the development of the B12 deficiency. And you can see that some of you will say this problem is not important, but nevertheless, it does exist.
So if you see a young adolescent, no vegetarian disease, it's hardly atrophic gastritis and hardly anemia, then possibly we should take into consideration it's not vegetarian, so probably such option is available. But now let's move to another important group of patients that developed B12 deficient anemia, deficiency of B12, and then anemia because of multiple treatments, polypharmacy. So we have to differentiate clinical and laboratory deficiency. Clinically, we see some symptoms that we will link to this anemia. The level of B12 could be normal, but nevertheless, mainly this is a problem of the elderly group. But what drugs are we talking about here? 3 levels, antagonists of H2 receptors, and we know that they can potentially lead to anemia, then proton pump inhibitors, which are stronger effect about the deficiency of B12 and anemia development, and metformin, last but not least, especially if the intake is longer than 1 year. These are 3 groups. And we have to understand that in such patients, these modes can be started. Inhibitors of proton pump inhibitors can lead to anemia. I'm not making accent on the antagonists, but proton pump inhibitors, and there is a number of reviews that are saying that up to 51%. So here is a review of the use of the proton pump inhibitors, which is associated with the anemia of cardiovascular outpatients management. Because they were taking PPIs for some reason, possibly there was ulcer or erosion or chronic blood loss here. And the schemes that are offered here in the 2020 with the suppression of H-chlor, 2 options here. This is gastric acid secretion reduced, and this is a release of B12 bound to protein or reduction of ferrikine. And if you look at big meta-analysis here, and we see here that clearly we see the reduction of the level of B12 in both groups, and ferritin level are not changing, iron is not changing, and ferritin is also reducing. And these are those who were taking for 12 months different proton pump inhibitors. And they were developing deficiency of B12 that may lead to anemia. And yes, B12 deficiency was developed, but no anemia, but the patients were taking for 1 year. If we try to translate this experience to metformin, then we will clearly see that the picture was the same, absolutely the same. When we say these are months and duration, 45.5 months, that this is longer than 4 years, or almost 4 years, and deficiency of B12 here, it's obvious. So when we have 3% of B12 deficiency, after taking the small dose, but in the other categories of patients, we will not have significant anemia. But if the administration is longer than 4 years and the dose more than 1,000 milligrams, then deficiency could be seen in 26% of the cases. That means every 4th patient. So from them, approximately half of them will face the deficiency of B12 that will finally lead to the development of B12 deficient anemia. And you have to keep it in mind. Let's move on. And that's the most vulnerable group. And I always refer to normochromia and hypochromia. Let's look at PPIs. Well, according to multiple data, one of the mechanisms that facilitates the development of chronic kidney disease is here. Mikhail probably will disagree because she said that's the last reason, but nevertheless, that's one of the potential mechanisms that should be taken into consideration. I think in such patients, there are multiple reasons for development of CKD. This is deficiency of erythropoietin synthesis and normochromic anemia. And here we need to take into consideration all the aspects. But what is the tactics? Let's ask a question. If this is anemia and B12 deficiency, if these are two different things, but it's easier to avoid it in the deficiency of B12, it's easier to catch it at the stage of deficiency, but not yet anemia, and then to treat patients, not wait until anemia. If your patient is taking histamine receptor blockers, or if your patient is taking PPIs, proton pump inhibitors, this patient is taking metformin, then think it over. Are you controlling it at least once a year, the level of vitamin B12? Or maybe the patient is already hypochromic, that could be associated with anemia. It is clear that if it's vegetarian or overuse of alcohol, there will be other reasons for the development of anemia. But in this case, what is in the competence of the GP to catch this deficiency? What should be the tactics? These are recent Canadian guidelines of 2023. They're clearly showing us if you suspect and if there are features of B12 deficiency development, we have 4 pathways here. I recalculated into the picogram per milliliter, but you can take it picomole per liter, but that's traditional scale for us. If it's less than 102, strong deficiency, 102, 204, probable, more than 204, no deficiency, and less than 8 histine, this is hypervitaminosis. And here the first step, start treatment B12 at least 2 months, How? Well, the dose is with normal absorption 250, in the normal up to 2000 microgram per day per os. If you use intramuscular IM, which is not applicable in adolescents, then we use 7-day cycles for B12. Then we assess for the second time if after our treatment the symptoms gone, but the level of B12 is higher than 300, then probably that was just B12 deficiency and we cured it. But if the symptoms are still persisting, but the level, no matter less or higher than 300, but the symptoms are persisting, so we should look for other reason. Most frequently, that was malabsorption related to, well, definitely with not gastric resection, and we know that, but probably some atrophic condition of the mucus, maybe some inflammation in the gut, intestinal inflammation, and it could hardly relate it to the deficiency of administration. So in this case, we also look for the other option, which is called pernicious anemia. So in the terms, very frequently, pernicious anemia is a synonym of macrocytic of B12 anemia, although it has its own mechanism. This is most frequently in elderly in the Northern Europe. So this is internal antibodies to the cells producers of internal factor Kasla. And we rarely see this situation in the younger than 60. There are 2 tactics here. We other many antiparietal antibodies, low sensitivity, high specificity, or Castle factor that's opposite, or to do Schilling test, which is interesting but requires time. This is Peros and IM introduction of labeled B12, and then we assess it in the urine, and normally it should be the result from 8 to 40%. If it's lower, then it should be just pirrose, and then we understand that the patient really has a problem with atrophy of mucosa, so there is no internal causal factor. So this is so-called Edison-Bernier anemia, or the other way around, we call it also malignant anemia, pernicious anemia. So in my presentation, I tackled just some aspects of hypotromic. So I not go into the polyetiology with hypothyroidism, and due to clear reasons, I was not talking about gastric resections or patients who had multiple oncological surgeries. I also didn't touch the issue of the misuse of alcohol due to clear reasons, although that's very favorable group, because for them it's easy to recover B12 deficiency and all neurological symptoms are gone. But nevertheless, I try to show you that hypochromia very frequently could be associated with some other reasons, let's say elderly people and pernicious anemia, CHF absorption, malabsorptions, iron deficiency, plus CKD, normochromic anemia. What could be the color indicator? Difficult to predict, and possibly we should be based on other tests, not only on that. For example, iron deficiency or ferritin level, and also B12, and compensate possibly all of them. And at the end of my presentation, I would like to remind you that the compensation of these deficiencies, if there is any, could be clinically significant, and maybe it will not influence globally the hemoglobin level, but it will influence the quality of life of the patient. So please don't neglect the compensation of these deficiencies, especially in the elderly group of patients and in the risk group of patients. And also please remember about the need of that regular, at least 1 year monitoring, if I'm speaking about a hyperchromic group, annual monitoring of B12 in those who have a long-term administration of metformin and PPIs, or those who have a long-term administration of H2 receptor blockers. With that, I would like to finish my presentation and thank you for your attention to this presentation. And I give the microphone to Dr. Batyushin. Well, Alexander, thank you very much for brilliant presentation. Well, to myself, I noted the following. When it's a clinician with deep dive into the clinic of internal pathology, with identification of some interesting aspects that normally are not so obvious, not so superficial, I think in that case, it's very, very beneficial, because sometimes we stuck to the standard presentations of hyperchromic anemia, and definitely we forget about multiple aspects, and you used a different approach, your unique approach, and within a time given, definitely you managed successfully, very successfully with the task. And now, dear colleagues, let me give the floor to the correspondent member of the Academy of Science, Alexander Arutyunov, and his presentation would be devoted to the issues of hypochromic anemias. So that means the part which is very actively used and probably the most relevant in the wider clinical practice, because hypochromic anemia, they are mainly associated with iron deficiencies, and this problem is associated, very frequently associated to quite bigger masses of patients, hypochromic anemias. It is related to hemorrhagic phenomenon with the massive menstruations or deficiency of iron intake. I think this problem is very wide, and that is why under the auspice of WHO, periodically we get these presentations about the challenges of hypochromic anemia. And I'm extremely happy to give the floor to Grigory Arutyunov, and then to have an opportunity to listen to the position of our distinguished colleagues, professor, academician, on how to diagnose, how to manage these patients, patients with hypochromic anemias, and definitely in iron deficiency spectrum, we have many different anemias, but this is not just iron deficiency, which leads to hypochromia. So Grigory Pavlovich, the microphone is yours. Good afternoon, dear colleagues. And thank you very much for the option to speak up today. Hyperchromic anemias are very relevant in the daily practice of the therapists. Let me draw your attention to some terms that could be really essential in our routine clinical practice. Dear friends, dear colleagues, let's create the basic vocabulary that will help us to be properly guided here. The first keyword is ferritin here. This is protein complex that's the main god of iron depot. 1/4 of iron would be in this complex. Then transferrin, that's another protein, that's main transport protein. It transports from gut to organs and tissues. And there are some more terms that we remember very clear from the student years. Let's say total iron in the serum. That's another interesting parameter that completely correlates with ferritin. That is why probably the need of measuring it in routine practice may be not very obvious. And there is another understanding, serum iron. Well, serum iron, what is serum iron? This is very variable because iron binding serum, that's quite philosophical idea that tells us what maximum amount of iron could be binded to transferrin. And you see both parameters are not 100% needed, but if we have a ratio one to the other, then we get very important parameter, very important for our practice. That parameter is coefficient of transferrin saturation with iron. And we got two very important parameters. Let's move on. Let's try to recollect that the iron adsorbed at a very limited piece of gut. This is duodenum and proximal iunal part. And there is no system in the organism that could actually guiding the excretion of excess of iron. So how can we support the balance? For that, there are two proteins. So this is teraportin, this is transmembrane protein, which is dealing with the issues of distribution of iron, increasing the absorption, increasing the saturation of transferrin, and there is the enemy of that, which is hepcidin, which is killing the protein teraportin, but hepcidin is doing its totally opposite. It's preventing the absorption and transport of iron. This is how balance in between two proteins is actually supporting the balance of iron in our organism. So let us proceed these very important terms. So there is a definition of latent deficiency of iron, which is very important. Here we need to understand that iron deficiency anemia never happens from nowhere. It is not like morning rain. No, patient moves very slowly to iron deficiency anemia. First, depot of iron should be depleted, and only then we will have manifest of the clinical manifestation of iron deficiency anemia. So let's appreciate latent deficiency, and we are doing the most important conclusion. So it could persist in the organism with normal level of hemoglobin, and then the therapists face very big challenges because iron deficiency should be identified at earlier stages. It's easier to correct than to treat later on the iron deficiency anemia. So let's introduce most important parameter. Iron deficiency is not the same like anemia. It's not the same. Iron deficiency sooner or later may lead to anemia, but it could persist with a normal level of hemoglobin because we just identified it that we have pretty big depot of iron that allows for some time interval, let's say, close that issue. So let us try, dear colleagues. So the scale of the problem, let's discuss it. We have to say that 9 out of 10 anemic syndromes, this is iron deficiency anemia. And this is most frequent problem that GPs are facing in the routine practice. And dear friends, let's look at another issue. Iron deficiency is very prevalent in the real world, and it is frequently seen, but there is a very special condition, which is age. And with age, with increased age of the patient, the more severe is iron deficiency. And also there are some mathematical models that can tell us that the age increase, unfortunately, per each year, it gives us 4% rise of anemia growth. So, and that's really a lot. If you look at the columns here, you can appreciate how these columns are increasing starting from age 65. So there are lots of things here And you see the young man, then puberty, then growing of the organism. So here there is a very big need in iron. So due to that, in the whole population, we have lots of patients or people, better say, with iron deficiency. But with time, well, then plateau comes, and then with time, starting from the age of 60, it will become the reason of attention. So you should pay attention from the GPs towards elderly patients. Now, a few words how to perform iron metabolism. So we understand that the iron itself is not surviving. It's protein complex. And when this protein complex transferring comes to the cell, so then it's caught by the receptor, goes to cell, and then gives us lysosome there, and then the protein should go back in order to perform the transport function. What do we need to know here? Iron accumulates and depending on the gender, it's from 2 to 4 grams of iron. And this is pretty big depot, and it takes pretty much time. It could hide the problem. And then, and in the previous stages of anemia, this is the first challenge for the therapists. Then loss of iron. Don't think that it never exists. No, it's not like that. During the pregnancy, up to 3 milligrams per day, and then lactation 2.5 milligrams per day, that's our loss. And in principle, each of us is losing from 1 to 2 milligrams of iron per day. Why? Well, because we lose epithelium, we lose hair, nails, whatever. And in the real organism, there is continuous loss of iron that we immediately replace from the products we are getting. When we lose iron, there is increased intensity of absorption. And in the healthy organism, it's a balance. But if not enough iron, and if it's deficiency of iron, what could happen in the organism? And then the therapist, the first thing that happens, mitochondrial change. It's a serious because it's reduced loss of energy. It will influence the functional capacity of systems and organs of our patients. That's the key thing here. This is not only mitochondrial involvement, but also second process, and it could be the problem of the hematopoiesis. It's also suffering. This is hypoxia, tissues and organs, so change of one microelement than the other. So it leads to the consequence of the pathological steps. But let's discuss the pathogenesis that we always should keep in mind when we talk to the patients. What could lead to iron deficiency in real clinical practice? So all these challenges could be put into several subclasses. Subclass 1, increased need of the iron. So who are they? So these are children, adolescents during puberty, and also professional donors that have potential donations. Then second cluster of problems, so this is malabsorption. These are problems related to the gastric pathologies. This is deterioration of the gastric acid synthesis, also absence of the stomach, probably small intestine injuries, partially proximal part of the small intestine. All that leads to the malabsorption, and that's quite challenging. Then gastritis, which is very prevalent, ulcerations, so all that prevent proper absorption. And now let's think that there is the third and probably most frequent challenge here in the real clinical practice, which is increased loss of iron. When do we see that? Again, this is polyposis, this is bleeds, also hernias of diaphragmal orifice, there could be micro losses of iron, also non-specific ulcerative colitis, also challenge of inflammation, also ulcerative disease, ulcerations that also could trend to the blood loss as well. And here you see erosive gastritis, which would be bleeding. So many challenges here. And this is how here we need to remember, if we face the problem of deficiency, we should always clearly remember what cluster or which vector our patient belongs to. Were very complicated slide, lots of red arrows, but they're all very important. Let me show once again that iron deficiency anemia here, it's a very prolonged process. Let's start from the following. The first thing that could happen, continuously deplete slowly for the organism depot of iron, very slowly, nothing radical is happening. We see the reduction of serum protein, but nobody sees that because nobody is checking this parameter in dynamics. This stage normally is beyond the paracentesis. We don't see it, so no manifestation. Patient is not complaining. But slowly and steadily, this stage, which we are calling slow depletion, comes to the other stage. And here, well, depot is lost. And here we can see a lot from the laboratory testing. Look what happens. Ferritin is reduced, and that's for sure. Also, we see the reduced saturation of transferrin. The level of protein transferrin is increasing at this moment, but here we see some clinical manifestations. Most frequently, not in 100% of the cases, but very frequently, we see asthenia. Hemoglobin stays normal. And with that, we see big mistake. Asthenia is not explained in the patients. So no anemia, so hemoglobin is normal, and asthenia is idiopathic. So we need to go deeper in such situation because this is one of the manifestations of iron deficiency in the human organism. But when this stage, sooner or later, we go to the next stage, that's already manifest of iron deficiency anemia, that's complete depletion of iron depot, and it's not available anymore in the human organism here. There is reduced concentration of hemoglobin, and the diagnosis is more than obvious to everyone. So main sense of these two slides I'm showing is to emphasize for the therapists that the process is not a single step, it's prolonged. This is continuum, and it's very important to understand patient in these dynamics, the change of his or her conditions. There is another important aspect, what influences the development of iron deficiency. There are multiple drugs that could be administered to the patients, and they matter in terms of iron deficiency. Let's look PPIs. Due to the fact that we change the synthesis of hydrogen cation, so there is a situation where bioavailability of iron is reduced. NSAIDs, no doubt. NSAIDs, they lead to gastroenteropathies that will facilitate the microlosses of iron. That's new classes of drugs that we started using very actively. This is SGLT2 inhibitors. Let's have a look here. Long-term administration increases erythropoietin synthesis, but the synthesis of erythropoietin requires a lot of iron. So it's all interconnected, and definitely the drugs that could block platelet aggregation, and definitely they could also give effect. So that would lead to micropathy. And finally, long-term of high doses of PPIs by itself could deteriorate the iron metabolism. And we should preferably take it into consideration when we interpret iron deficiency in the human organism. But manifestation, because they are operating with clinical positions, there are two syndromes important here, which allow us to dive deeper into the problem. So features of cytopenic one, which we can look at looking at our patients, and anemic syndrome. So cytopenic syndrome is something which we remember very clearly from therapeutics, but very rarely see in the real life. So changes of the skin, of the nails, change of the smell and odor. So everybody remembers that. So love to something not cooked, so raw meat, raw products. So that's not specific syndrome. And well, you can suspect that, but the poor diagnosis, you cannot simply. So this is how it looks like. And I will show you the nails here. Well, it could be very different ones. So they're very fragile and they're cracking. So no specific syndrome, but nevertheless. There is anemic syndrome. That's of total non-specific features, but because here we see reduced employability, fatigue, weakness, tiredness, and also in some situations with very severe anemia, we see another symptom which is important for the therapist. This is systolic noise. Systolic noise in anemia could be heard at the first point, and it has a unique capacity. It's not conducting. Don't miss it with the mitral failure. No, it's different because it's always going to the axillary part, but the anemic noise is not going anywhere, no conductivity. But this is typical for extreme stages, for very severe anemia when the viscosity of blood is dropped dramatically. So what physical examination could give us? We should say that as the symptoms, visual symptoms are not specific, actually, we cannot see that and we cannot be sure in the diagnosis in this case, then we should use laboratory testing. So what are the most important laboratory parameters that help us to make the diagnosis of iron deficiency? First is the ferritin of the serum. Here in the blue column, you see normal range. So what is the challenge here? Because ferritin is acute phase protein, and if anemia and inflammation are overlapping, so it's very difficult to be guided by that, because ferritin would be increasing in the concentration of blood, but the figure of ferritin less than 100, especially for patients with CHF, with CKD, then you should be very serious about this patient. The second figure is a saturation, transferrin saturation. Let's remember the level, less than 20, TSAT tells us about iron deficiency in our patients. But what about standard conditions, serum iron? So that's very high individual variability in number of guidelines. They even don't take this parameter to measure. Then the total iron binding capacity. Well, that's nicely correlating with transferrin. So probably we'll get more information when we measure transferrin, but something else. So with laboratory methods, we are done. But now let's look at innovations that are coming and then allow us extend our understanding. Erythrocytes that we are analyzing, they have 120 days in their cycles. Yes, they live 120 days. We want to know the level of iron metabolism right now. And there is a new parameter which is actively measured now. And it can be measured in the labs. In the private labs, this is red hemoglobin, which is hemoglobin in reticulocytes. Well, this parameter gives us very useful information on what is the level of iron online, what's going on in the organism now, because maturation requires 60 hours. In fact, online. So we are detecting this parameter. I know the thresholds and they're shown here. And then I get two important parameters. This is hemoglobin in reticulocytes and also in erythrocytes. I can find arithmetic difference in between two, and the difference should be positive in the healthy case. But if it goes to the negative parameter, then it means then there is a reduction. There is a reduction, and this is very big reduction. Depot of iron is dramatically reduced. But traditionally, what do we have to pay attention to as GPs looking at the clinical blood test results? We pay attention to the morphology of erythrocytes. This is hypochromia, this is anisocytosis, and also microcytosis in our patients. Well, such characteristic, we remember it very clearly. It completely coincides with anemia of chronic diseases. But how to differentiate iron deficiency now from anemia of chronic diseases? Well, that's quite challenging situation, and possibly the best approach and the best supportive here, this is at the level of ferritin in serum. In iron deficiency anemia, we will always see the reduction of serum ferritin, but serum ferritin would be normal or even increased in the patients where we see chronic disease anemia. What can we recommend in this case? What can we recommend to the GPs after the primary examination of the patient? What to administer, what to check? We can say, okay, ferritin and transferrin saturation. We can look at other conditional parameters, but the most important, we can assess functional status of the organism in terms of iron discontinuation. So right now, the situation is right now, so we need some more other methods. And here there is another important sequence which is recommended. This is search for the blood loss source, if we are thinking about it. First, it is esophagogastroduodenoscopy, then colonoscopy. Colonoscopy, if we see nothing and we don't see the reason where the blood loss is coming, only then we go to the small intestine. So first, it is esophagogastroduodenoscopy, then colonoscopy, and then small intestine. Several postulates are important. Iron deficiency anemia is not treated by diet. This is a very frequent mistake. And there is no need to increase iron products. That's complete mistake, but this is not the reason to discuss in GP's office. What is a reason is a strategy to select the treatment for our patients. Patients with iron deficiency or manifesting iron deficient anemia. So the first question, which drug to select? Is it IV or Peros? What is preferable? What is better? And here, clinical assessment of the patients is very important. That means how advanced the disease is the situation requires urgency, and how fast we should get the result. If our patient is refractory to the treatment with Peros, so let's say there were previous attempts and they're not effective, and due to some neurological reasons or severe condition of the patients, and the patient cannot swallow properly, then definitely we should think about intravenous iron. So the more severe the patient is and the faster you need the effect, the best choice could be specifically IV form. Please don't forget that in a number of conditions in our patients, we have a syndrome of malabsorption as well. For example, in a patient with severe CHF, we always see malabsorption, and Peros drugs would not be properly absorbed. The second thing we need to resolve, which iron to select, 2-valent or 3-valent iron. Well, 2-valent iron, it's very well known, gluconate, chloride of iron, fumarate, sulfate, and other salts. So the question is, why two-channel enterocytes have more channels for 2-valent, and if it is so, then the effect would get much faster with 2-valent ions. But 2-valent iron, it's very severe drug that creates lots of adverse events, definitely, because 2-valent iron could interact with oxygen, hydrogen peroxides, with lipids, would create lots of adverse events, and the need to discontinue. And we measured this figure. About 60% of the patients would have adverse events on the 2-valent iron, and also there are very negative adverse events for our patients, and this is coloration of the teeth, and patients stop after the coloration of the teeth. Now let's look at the 3-valent iron. 3-valent iron is highly safe, no adverse events, but the efficacy comes later, so it works slower. And again, we are facing with the importance of time. So what time is available? Do we need urgent correction, or do we have time for that? And if we can wait, then the effect would come very slow. Then yes, please take 3-valent iron. If not, then select 2-valent ions. And please remember that's quite toxic. But for the pregnant, normally it's 3-valent iron. Now let's look at salts. Which salts? Organic salts or non-organic salts? We have to say there is a clear rule. Very famous non-organic, this is sulfate, very toxic, creates lots of adverse events and up to necrotic changes, and it is prohibited to be used in pregnant. And we clearly understand that organic salts are much easier to tolerate. Another issue here is a selection of treatment and tactics of long-term management of the patient, and what is inside. Is it combined option or not? Because drugs containing iron, they have two main components, which is copper and manganese. Do we need to look at that? Of course, because copper provides antioxidant protection and it reduces the adverse event rate. But manganese is a must to perform imports of the proteins into mitochondria. Is not enough manganese, then the transport complex of transferring iron and referral of iron to mitochondria would be slowed down or would be even suffering from that. And this is a difficult situation in the organism. That is why definitely the introduction of two other microelements, which is copper and manganese, is a must because it improves the clinical situation of our patient. And finally, we have another important question. What should be the duration of administration, and how do we assess whether the effect comes or not? Then secondary visits, sometimes next further visits. What should we look at in this situation? Well, first, we should look at the dynamics of hemoglobin, then the dynamics of hematocrit. And then when we see the significant changes, well, not earlier than day 14, and also we need to assess whether day 14 up to, let's say, day 28, what happens then? Any dynamics here or not? Is it positive or not? Day 28, first month is done. You don't see any dynamics with treatment. So what to do next? So let's forget about very simple reason when the patient is not compliant. Let's say patient is compliant. So probably diagnostic search was wrong. Start from the very beginning. This is an unacceptable situation. And now let's go back. We see the success. Then how long do we wait for success? And how long do we wait for the change of the clinical and somatic situation in the well-being of our patients? Because symptoms related directly to anemia should disappear within 60 to 70 days. Yes, and that's a must because you double check and you see that the symptoms are disappearing, and then you provide maintenance doses in the treatment of these patients. And in parallel, you would provide search of reasons that actually was the reason of this iron metabolism change and leading to anemia in the patient. So let's draw attention to another important thing. After the normalization of hemoglobin, we should go back to the minimal doses. So in fact, we mean maintenance doses in our patients. Please make correct conclusions from that. So the disease was developing very long. So resolving acute manifestation, we still follow up the patient. We provide maintenance and we support high compliance to treatment. And this is how we preserve maintenance doses in the patients, saturate depot with iron. Can we expect overdose? Yes, of course. Yes, of course. What do we see here? Look at the manifestation. Instead of improvement, you would see constipation, change constipation to diarrhea, vomiting, nausea. Sometimes seizures may come, fatigue, hyperthermia. So please try to suspect in this situation overdosing. And if you believe that actually overdosing took place, such patient requires hospitalization and introduction of IV treatments that would reduce the level of iron in the human organism. But what if there are absolute contraindications? Absolute contraindications, this is anemia not related to iron deficiency. And this is one of the biggest mistakes in the real clinical practice. You see anemia and then patients getting administration of two drugs immediately, which is vitamin B12, folic acid, and iron drug. And then we need to resolve in that. And it is not possible to find what is the reason. So this slide is not to be remembered, but just to keep it in mind. So the lists of all treatments with iron and the arrows here show IV forms of the treatments. And now let's approach to PEROS. PEROS, here you see salt and non-salt base forms. Let me draw your attention. Among salt forms, you see yellow. This is iron, 2-iron, which is fumarate. So that would be very fast saturation. And the bivalent gluconate, also very fast reaction to that. And we can get the response very fast. So why they're separate. And non-salt, this is polymaltose complex, which requires special attention. Let's start from polymaltose complex because actually it's very similar according to its structure to ferritin. So it makes it easier to enter the circulation and delivery to organs. And very important is the second aspect. This complex is absorbed in all spectrum of pH, so no matter. And this is how it's very highly effective in different functional conditions of the gastric mucosa. As we see not at all antioxidant properties, then it would provide minimal rate of adverse events. And this is very interesting complex that can be used, also 3-valent ion of polymaltosate complex. There are some more approaches. We're approaching bivalent forms, Perros forms. So these are 2 forms that are completely safe. The minimal rate of adverse events, this is iron gluconate. And I'm drawing your attention here, and also fumarate. They're both recommended, and that's how they're shown with yellow here. They're even recommended to the pregnant because they're totally safe, and they have minimal adverse event rate. If you select Perros forms, that you should know that we will select the dose which is equivalent to 180 or 200 milligram of iron per day. That's the key thing here. And another moment, you're looking at biochemical tests of your patient. The level of ferritin in the blood serum is lower than 100. Forget about Perros. You immediately go for IV form of iron, but IV form requires, well, special knowledge as well. This is so-called theory of 3 steps. Let's have a look. We make the first step and we need to identify the need of one specific organism in the severity of iron deficiency. So how much is needed? What do I need for that? And please look at the upper part here. And this is body weight of the patients. So very frequently we see this mass from 70 kilos and higher. And the second is the level of hemoglobin. So I'm looking at the level of hemoglobin and I see that with hemoglobin less than 100, the need of iron in one specific patient would be about 2000 milligram. So that means we personalize the problem at the level of each patient. Then next step, what dose should be selected, and the most important, how to introduce it. So we select IV form of treatment, and please appreciate that IV form could be introduced as a bolus, or it can be simply injected and it will influence the dose. If we take pharinject, which is the best evidence base, and it was tested in patients with strokes and MIs, and patients increase tolerance to physical exercise, peak consumption of oxygen, increased well-being, increased level of hemoglobin. So pharinject is really very useful. So all those who treat patients with severe iron failure, they agree with me. Patients like getting a new breath, so they're more active. They start walking around. They think on what they're going to do at home. So it's very important to change the level of hemoglobin. Is very important. So we influence the functional condition of this patient. And then what is very important, especially for severe ischemia patients, stroke patients, so and the question of their anemia is sometimes forgotten, and this is not good because we have to intervene into this anemia. Beside baseline quadruple treatment, we also should influence the prognosis of the patients. So currently we select, let's say, bolus introduction, so it can be just 15 milligram per kilo per weight. The maximum dose is 1000 milligram once a week. But if we select drip, then it could be 20 milligram per kilo. But anyway, you shouldn't go beyond of 1000 milligram of iron. That's a maximum single dose per week. So we introduce the treatment, but when to look at success. So 1 week passed, second week passed, we calculated how much we should give. And please remember, it's very important that in 2 weeks, we should change patients, more active, better mobile. And you will see that patients are getting life energy, life power, if you can call it this way. Actually, it's seen with BRI. Special group of patients, hemodialysis patients. So for them, dose should not be higher than 200 milligram of iron. It is clear, it's hemodialysis. And we move on, and then step 3. So if I make a decision on the introduction of treatment, but what pace? What pace then for IV rates? IV rates. The most frequent doses here, the bottom line. You see the duration of introduction, 15 minutes. So it's minimal time, 15 minutes. Don't be in a hurry. No hurry here. It's important because it would give you minimum adverse events. There are not many of them, but it would be minimized. You just minimize it. And another thing, in the third step, we ask a question. If I make a decision to introduce like a drip, IV drip, then in what volume of fluid and what should be the fluid? Well, this is definitely saline. That's the main solution. And the frequent challenge is the last line here. You can clearly see that for the 15 minutes, 250 milliliters of such solution is introduced absolutely safely. But you reach the success in treatment iron deficiency anemia in your patient is not seen. What about side effects? Well, from those that attract attention, if you forget about headache or flushes, which is minimized, and emotional patients, they describe it how they feel the flushes, but in fact, side effects, I can tell you from my own experience, side effects are minimal and very rare in our patients, but the changes of phosphate, then yes, it is seen frequently, but it's independently resolved. And it does not require any special correction here. So you can identify it and you can follow that and then nothing terrible happens to the patients. Well, dear friends, once again, I would like to thank you for the interest to this challenge. And I have to say that in practice of the GP, it's very important to understand that iron deficiency anemia is never sudden, It develops very slowly and steadily. So we should try to catch patients at the level of iron deficiency, and IV forms in the severe type of disease are priorities to us in the selection of tactics of treatment of the patients. Once again, thank you very much for your attention. Dear Grigory, thank you very much for fantastic presentation. And I think, yes, truly, the topic that you selected is very relevant, although there is hyperchromic and it actually guides your position to the number of other challenges related to possible reasons of hyperchromic anemias. So you spoke about children, adolescents, young females, pregnant, and also look into the polymorbid pathologies, chronic pathologies, and other different aspects of the development in hematology, pathology of kidneys, etc., etc. So we have just few minutes to take several questions here. And then, as we promised, we will have the procedure of the closing ceremony of the Congress. So we have just a couple of minutes to answer the questions you sent to us, and you can see them in the chat. The first question, what is your opinion about prolyl hydroxylase inhibitors like roxadustat and CKD? Well, my position is definitely positive. Definitely, yes, there are two very important advantages of these treatments here versus erythropoietins EPA-containing treatments. First is the drug is enteral, so this is tablet, so this is not injection, prolyl hydroxylase inhibitor like roxadustat. And the second one, we can overcome the resistance in the EPO stimulating agents treatments to overcome resistance. So very important that drugs like roxadustat, debratostat, logostat, and number of others which would come to the market in the near years. And roxadustat is already available, at least in the Russian Federation. Alexander, would you like to add on something? No, definitely not. But what about the second question? What do you feel about intranasal use of B12? Well, there is such a position, and actually it's a marketing design. They believe it's simplified delivery, faster delivery, and interaction with liposomal membranes. But I think in principle, this is alternative to IM or tableted one. So they believe that delivery would be faster, and there are high doses up to 5,000 microgram. But yes, it is used, and actually the use is very effective and safe. Am I right saying that mainly we speak about the situations when these treatments, when patient needs this treatment as a chronic one, not the acute one, hospital one, but let's say administration within 2, 3, 5 years. So there will be no gastric problem here. And of course, you're absolutely right. And now the next question here also to you, how to formulate the diagnosis of hyperchromic anemia or microcytary anemia. So what is your vision and how to formulate the diagnosis? I will put here the severity as well, and moderate or mild or severe, and also macrocytary probably. Also, you can mention hyper and hyporegeneratory, but that's another story. I think that's enough. Next question also to you. Maybe I could give short comment on that. Iron 30, ferritin 50, hemoglobin 100. What is the management tactics for such patients? Well, not much data, of course. Who would start? Well, I can say just a word, few words. Well, it's normal with iron, ferritin with normal, less normal, but hemoglobin is low. So we can think that this is sort of anemia. Which one? Definitely not iron deficient, but which one? Well, not always. We need to know erythrocytes, and then through a color index, we should look at it, whether it's hypochromia or not. But yes, it may not be iron deficiency, but possibly it can be. We should agree that in this question, we have a complete spectrum of all possible anemias could be hidden behind that. So answering the question, what to do with such patients, probably we should mention that such patient needs a very comprehensive approach, comprehensively examined to identify the genesis of this anemia. So this is normochromic, hyper and hypochromic anemias. All of them could be here. And as Alexander said, theoretically, it can be iron deficient anemia, although the iron in the serum is 30. But let me remind you that free iron in the serum is not, let's say, the guiding one in our interpretation of etiology of anemia. This parameter is used very rarely, especially in the recent years. And as Grigory said before in his final presentation, transferrin and ferritin, so all these parameters which reflect ferrokinetics in patients with the developed anemia is very important. Then patients with anemia and chronic heart failure, which treatment is most preferable and what should be the administration route? What do you think? I think Grigory already covered that question, and if he has any comments, he will be reconnected now, and hopefully he will be able to give us some more extended comments on that. Next question about chelated iron. Yes. Well, there is such route, chelated iron, and we know about it. Well, to say that, let's say to say that this is alternative to the pharmaceutical treatments which are used in the treatment of patients with iron deficient anemia, I wouldn't put it this way. Because again, category of biological additives, I wouldn't put it this way as well. I think it's intermediate position. I would very cautious in my positioning, but they believe that probably it's a little bit of better bioavailability due to the chelated form. And well, to say that this is, let's say, something common, and I would be very cautious about it. I will support you. Next question. This is particular clinical situation, that's nausea and abdominal pain, whether it's a reason to switch to parenteral iron administration, particularly in pregnancy. So if we give a tablet and then patient complains to nausea, abdominal pain, and patient cannot tolerate, then possibly there will be no absorption of treatment. Can we select as an alternative of parenteral route? Well, I agree with you. Yes, we can. Beside pregnant, I would identify a category of patients with different endogenic intoxications. I deal with nephrology. Patients with renal failure, it is exactly the category that is very frequently, very poorly tolerate enteral iron, and they have nausea, vomiting, they have constipations, and constipation for such patients with renal failure is a way to additional uremic intoxication, and the majority of uremic toxin, they are released in the lumen of the colon, and due to the uremic enterocolitis or enteropathy and colopathy, the iron treatments consumed enterally, they have very poor absorption. That's why for dialysis patients, that's for sure, we have advantages in the introduction of treatment during dialysis. It should be parenteral route, which should be preferred. Well, speaking about pregnant, possibly yes, but please remember that if the drug is enteral and is taken daily, and parenteral option, it's another story, and Grigori spoke a bit. Parenteral should be used as a course, as a long cycle. Another question here, can we use iron treatments in septic patients, so patients with sepsis or, let's say, with active infection? Should we stop iron for the period of acute bacterial infection? Well, Alexander, probably they mean here that such patients with sepsis, are the ones that are very active consumers of iron, right? Yes, correct. Bacteria and fungal infection are very active users, and also during the infection, we even can see the anemia of chronic infections when macrophage is becoming siderophage using the iron. But in fact, yes, there are publications, and I understand why the question comes. There are some publications that the use of any available forms of iron, by the way, beside chelated iron, so to septic patients could provoke the increase of infection, the worsening of infection. But I have to say that here, further studies required, definitely further studies required, because some iron preparations could or could not be given. We cannot say that, but I probably agree with you that very many aspects stick to the position of not use iron under sepsis or bacterial infection. But definitely evidence-based data is very limited. Well, Alexander, I think when we fight anemia in septic condition, we could find some alternative, acute alternative, let's say hemotransfusion or something else. Yes, of course. But this is a very special category of patients, which we see in the acute situations, polyorganic failure syndrome, because when you introduce iron, you do hope for a reticulocytary crisis, and then within 1 or 2 weeks, the patient will start improving the situation with ferrokinetics, and also it can happen that this patient simply has this 1 or 2 weeks, and what we require is quite a fast solution right here and right now, because today its hemoglobin is 50, and it is today you provide hemotransfusion. And that's another question, also very interesting. And this is anemic syndrome related to iron deficiency. This is pretty frequent situation. And can we introduce ascorbic acid to improve iron situation? So here we need to add what sort of iron, 2-valent or 3-valent iron. So if we speak about the treatment with 2-valent iron, then definitely it's without ascorbic acid, then absorption would go worse. So maybe you can recollect some other options. No, I cannot. And I totally agree with you here, totally agree. Well, and another final question here. So our audience telling us that after gastroduodenoscopy and then small intestine examination, what is the examination of small intestine? So they ask about the instrumental tests, how we can find the reason for the development of iron deficiency and post-hemorrhagic anemia. So if this is FAGS, then we can check the duodenum and esophagus, and there are methods to study small intestine, and we have to say that in the ambulance practice, they're not used. So these are complicated telemetric methods when capsule can be taken, endoscopic capsule, then in the process it's moving and then it's recording everything which is seen along the route. Then patient is specially prepared to that. So all that is quite challenging, and probably such studies mainly belong to the category of scheduled studies. What do you think, Alexander? What do you think? Yes, I think I agree with you. I just clarified about Grigori's availability. Well, colleagues, with that, we should inform you that our symposium is finalized. It was final symposium, and we have quite busy schedule within few days here. And finally, we can sum up and hopefully wrap up. And the technical committee is reporting that currently we can listen to our lead correspondent member of Academy of Sciences, Professor Grigory Arutyunov. And Grigory, are you connected? Are you with us? Yes, thank you very much, dear colleagues. Thank you very much. Well, let me say a few words, a few wrapping up words. Well, these 3 days rushed as a blink of an eye. They were very intense and very interesting. I would like to provide some statistics. So for these 3 days, we had 85,000 connections. That's really a lot, really a lot. And I would like to express the words of gratitude to those who actually make it possible to connect to the Congress. And it was a great honor for us and great responsibility for us. And we're extremely happy about that. We fully understand that level of responsibility we have taken, and we try to meet your expectations and over exceed your expectations and your trust. For last 3 days, we have 4 halls working from 9 to 6. More than 100 experts, speakers made their reports and presentations speaking about the innovative data. We had sessions of latest breaks in science, and I want to draw your attention, and I would like to draw your attention to the scientific competition that was carried out this year. I will speak more about it because we have lots of awards here and openings. Now a few more figures: 32 symposia, 4 workshops, which is important, 1 plenary session, 2 fast-track sessions, 2 panel discussions, and very important are the countries that connected to us and gave us the trust: Russian Federation, Kazakhstan, Armenia, Belarus, Kyrgyzstan, Moldova, Uzbekistan, Azerbaijan, Georgia, UK, Tajikistan, Germany, Spain, Mauritania, France, Thailand, Turkey, and the Netherlands. And thank you very much, colleagues, for the connections, and we are very grateful and honored. And now I would like to draw your attention to another important moment. For the first time in the story of the Congresses, there were 232 works sent from 10 countries: Russia, Armenia, Kyrgyzstan, Turkmenistan, Uzbekistan, Kazakhstan, Belarus, Germany, Georgia, Azerbaijan. They were sent for the competition of scientific projects. Well, and it influenced very strongly the work of our scientific committee. And today we had quite a symbolic day because April 7, 1948, the WHO was established. And this is a day which is called the Day of Health. So exactly this day, we sum up the results of that fantastic scientific competition. So let me say a few words how the work of scientific committee looked like. We analyzed 234 posters. 234, 90 went to the second route, and they were distinguished like this: 50 were published as abstracts, 33 publications are poster presentations, oral presentations, and 7 publications got a special award. They were identified in a special session as oral reports, all the reports in the framework of the Congress. So let me name the laureates that got the highest reward and made their presentation. This is Opieva Kristina, Tomsk, Russia; Sifiko Dvalishvili, Georgia; Tbilisi; Kulagin Yegor, St. Petersburg, Russia; Bimukanov Azamat Maratovich, Russia; also Dmitry Gavrilenko, Dementieva Anna, Russia, Moscow City; and Stanislav Khlyamov, Russia, Kursk. Congratulations, congratulations, and we believe that this is a very strong start for your future scientific career. And now let me move to the most exciting. This is the stand poster competition. So the first position and the only one, first and the only one, this is the work presented by the team of authors. This is Chashan Mikhail, Королева, Федорович, Дадаева, Емельяненко, Горшков, Mikhailova, Drapkina. Drapkina Oksana, and this is Russia, Moscow, and this is assessment of the microcirculatory internal phalanx in males with impaired glucose tolerance via body plethysmography. And the first position, and this is a golden prize. The second position, the team of authors, Vasilchenko, Lvova, Gur. This is Belarus Republic. This is Minsk. This is deterioration of organ functions in patients with TB using international classification of functioning and limitations of life and health. Second position, silver award. Ahiarova Karina Erikovna, Ufa City, molecular predictors and clinical and instrumental specificities in hypermobility of joints in young patients. The third position in the stand presentations, this is a work for third position. This is the team of Yulia Petrova, Raifa Ivanova, Kazakhstan, Semey City. The problems of the selection of adequate therapy for comorbid patients with rheumatoid arthritis. The third position, the team of authors, Usmanova, Razikjaev from Uzbekistan, Tashkent City, the level of MMP9 and type 1b dependence from histological picture of carotid arteries. And the third position here, that's the team of authors, Bogdanov Romanova, Moscow, Russia. This is personalized and Mediterranean diet for the composition of the body in patients with obesity and atrial fibrillation and their comparative characteristics. Well, dear friends, so we'll stand presentations, and I'm extremely pleased to announce that the special award of Presidium of Russian Eurasian Association of Therapists is given to the team of authors, Tan Roberdieva, Kurbanova, Amandurdeeva from Turkmenistan Republic. This is Ashgabat City with the presentation Futures of the Cause of Systematic Lupus Erythematosus. So that's very strong publication that really deserves the special award of the Presidium of Eurasian Association of Therapists. Dear laureates, we sincerely congratulate you and wish you all the best. We wish you a very long and nice road to the future of science. You made a very important step, so congratulations. Dear friends, I would like to thank the huge team that was working behind the stage in order to organize this Congress. This smoothless broadcast was organized. Fantastic work of our simultaneous interpreters, fantastic work of the editors, and definitely great work of the steering committee that had been working for the whole period of our Congress. And probably it deserves the highest praise. And on behalf of all of us, the whole audience that was listening for 3 days of this Congress, we express huge gratitude to those who never saw on the screen, those who have been working for these 3 days from early morning till late evening. Dear friends, it's very sad to say, but our Congress is over. It looks like it was quite successful, and we are endlessly grateful for your trust and confidence you demonstrated connecting to us and participating in the Congress. We value that greatly, and we try very much to keep the bar as high as possible and then continue getting your trust and your attention. With that, we say goodbye, and we do hope we meet again in September at our September conference that will be called Innovations in the Internal Medicine. So hopefully seeing you again also in November at another interesting forum. This is an international regional conference that will be carried out with the motto From Volga to Yenisei. With that, hope you again. Thank you very much and goodbye. We love you and we do hope that we will meet all your expectations. Have a good day. Goodbye.
Thank you.